in our journey of our centenary year. 100 years of legacy, progress, and transformation. Today, as we reflect on the past, we also look ahead to the future, drawing inspiration from a century of achievements and challenges overcome. This is a moment not only to celebrate where we have come from, but also to engage in thoughtful discussions that will shape our path forward. We are incredibly fortunate to have with us today a distinguished panel of experts whose diverse insights and experiences will guide us through. Their collective knowledge is invaluable as we reflect on the lessons learned over the last 100 years and envision the next century of innovation, growth, and social impact. As we embark on today's discussion, let us remember that Centenary Year is not just a commemoration, it is an opportunity to reaffirm our commitment to the values and vision that have brought us here. It is time to look back with gratitude and forward with optimism, knowing that our best days lie ahead. On behalf of Staff Society, I would like to thank each of you for being here to witness this pivotal moment. Your presence reflects your shared commitment to the values we hold dear, and your participation today plays an integral role in shaping our future and building together. Today, we will be engaging in discussions over social media, artificial intelligence, medical training and practice, and clinical relevance of publications. I would like to thank each of you for being here. So without further delay, I invite you all to engage in this enriching dialogue, and I look forward to the inspiring conversations that will unfold. Thank you once again and welcome to this event. I now hand over to Dr. Sikandar Banu for further proceedings. Thank you.
Good morning, everyone. Myself, Dr. Sikandar Banu, Additional Professor in the Department of Anatomy. It is an honor and privilege to welcome you to this panel discussion that's on the social media. It is a double-edged sword in modern healthcare. Social media has revolutionized how we connect, communicate, and share information. Platforms such as Facebook, Twitter, Instagram, and LinkedIn have brought the world closer, enabling instant communication across continents and the cultures. These digital spaces have become essential tools for personal connections, professional networking, and exchange of ideas. Social media has transformed the world in ways we could not have imagined a few decades earlier. So let's begin that. For that, it's my privilege to introduce distinguished moderators who will be steering today's panel discussion on social media. Our first moderator is Dr. Siddhi Chikhalkar. As a highly respected professional in the field of dermatology, she is an additional professor who is having more than 40 international and national publications and more than 100 presentations in various workshops and conferences. She got Best Thesis Award in 2004. She got Best Poster Award in 2013 at International Conference in Dubai. She got Best Award for Priyadarshini Award by All India Journalist Organization for Best Work in the Dermatology in 2015. Her areas of interest are aesthetic dermatology and trichology. So I would like to invite Dr. Siddhi Chikhalkar ma'am on the dais. Please join me with welcoming ma'am. She will be guiding our discussion with their signature clarity and thoughtfulness. Joining her is Dr. Shilpasri Palsule, a well-known figure in the domain of hand therapy and spinal cord injury rehabilitation. She is working as assistant professor in the occupational therapy department. She is a member of ethics committee and recipient of Fellow of Academic Council of Occupational Therapy Award in 2022. Her areas of interest are hand therapy and spinal cord injury rehabilitation. So I welcome you, ma'am, Dr. Shilpasri Palsule. I hand over the mic to Dr. Siddhi ma'am for further proceedings.
Good morning, everyone. Good morning. Do you agree that social media has taken up most of our time daily? Yes or no? Yes, right. And this is applicable for both students as well as teachers. In fact, it is applicable for everyone from all professions. Social media is important and powerful tool for us to share information, to educate our patients in a very interesting manner. However, but its misuse leads to challenges and ethical issues. And today we are here to discuss all about use of social media in the medical profession. And we have with us expert clinicians who will help us to navigate through this tricky topic. So today for this session's total, we have 6 panelists from our own institute. Our first panelist is Dr. Vinita Puri. She is professor and head of the Department of Dermatology. Next slide, please. Okay. Vinita Puri is head of the Department of Plastic Surgery and Burns. She is currently the president-elect of the Asia Pacific Burn Association, and among her numerous achievements, she has honored with Fulan Devi Gupta Award in 2021. She has many awards on her credit for her outstanding work in the field of burns. She also has an impressive list of publications and presentation to her credit, and her areas of interest is mainly in the hand surgeries, and she loves high altitude trekking, photography, music, painting. So in short, she's a superwoman, multi-talented lady. Please welcome ma'am. Our next panelist is someone who literally has social media in her name. Can you guess? Very good, SM Shraddha More, a dynamic personality. Do you agree? Face of KEM social media. She was invited as a TEDx speaker to share her insights on time micromanagement. Shraddha is highly popular not among faculty but in students also for innovative medical teaching. And she is a famous medicine game developer and also podcaster for GSMC KEMH. Welcome Dr. Siddhi. Sorry, Shraddha. Sorry. Our next panelist is Dr. Sriraj Talwadkar, is an assistant professor. So you can guess how popular Dr. Sriraj. He manages our official GSMC YouTube channel, Beyond Academics. He is a passionate travel food vlogger with over 3,000 subscribers. Dr. Talwadkar is highly regarded among students for his creative medical memes, which makes learning both engaging and entertaining. Additionally, he has popular Twitter account amongst medical students across the 5,000 subscribers and followers. So I welcome Sriraj.
Good morning, everybody. Our next panelists are also very senior people here. So our next panelist is Dr. Balaji Ironi. He is a professor from our very own Department of Cardiovascular and Thoracic Surgery. The applause that he receives is telling that he is part of the first successful heart transplant team at KEM Hospital. Sir has 40 international publications, 10 presentations, and he has a keen interest in heart and lung transplant surgeries as well as aortic and aortic arch surgeries. Welcome, Dr. Balaji. The next panelist here is our very own Vijay Kumar Singh sir. Sir is a professor and head with the Department of Community Medicine at St. GS Medical College and KEM Hospital. Sir has 24 publications to his credit with an equal number of presentations. Sir has been an award winner at the paper presentation at the conferences at Aurangabad, and he takes a keen interest in medical education and research. Our next panelist is Dr. Anita Chalak, Madam. So, Madam is the professor and head of department with the Department of Biochemistry, St. GS Medical College and KM Hospital. She has 40 publications to her credit, and she is among the persons who has been influential in developing implementation of blueprinting in theory assessment with the MUHS. Madam has received an appreciation letter from the Vice Chancellor of MUHS. This is a big achievement for us. Madam has also received an appreciation letter from the National Council of Occupational Therapy when she has guided the faculty of OT for training in competency-based curriculum. Madam is interested in laboratory medicine as well as medical education and technology. So big applause to all our panelists here. And without any further delay, we shall start with the panel discussion. I welcome you all for this panel discussion. So Dr. Siddhi and myself will be moderating. So my first question. So initially we would like to talk. Am I audible?
Hello.
Hello. Hello. Hello. Hello. Hello. Hello. Chal.
Hello.
So my first question is to Dr. Vijay Kumar Singh. Sir, do you think that social media has changed the way that we medical professionals now communicate with the patients and public?
First of all, good morning, everybody. And Madam, thank you very much for inviting me over here as a panelist. Coming to the question, I feel the way of communication through social media is changed too much. Doctors find very easy way to connect with the patient with the social media. And also, they are there to answer all the queries. So what they are expected is to give the treatment in detail, in writing. So for the patient, it becomes very, very convenient and easy to get the treatment which is explained in a written words. So patients, they find they have time to decide. They understand, and they have then choice whether to go about it or not. So these are the ways by which, and communication as a traditional way, like when we used to call patient and talk to face, was a different. Like it was giving a human touch. But here we have lost the human touch when it comes to social media. There are chances that doctors can do some, the doctor's prescription or advice can be misinterpreted by the patients when they don't understand. And then there are chances, because of this way of communication, then there will be a lot of problems, maybe legal problems may face by the doctor. Okay. The only solution which I find for this is if doctors, if they are attached to some institute, they represent some institute, then these messages are being scrutinized, they are standardized. So that becomes easier and authentic information. So I think this is the way that we have lost the human touch, and what we talk about in medical education now here is ATCOM is getting, it gets fixed up, okay? And this way of communication we are losing, we are blurring the relation between patient and doctor.
Thank you, sir. Dr. Balaji, would you like to opine on this?
Yeah, absolutely. There has been an undeniable, remarkable change or altered in the communication between the professionals and the patients. But it's not always for the betterment of the patient as well as the professional. For example, this platform, they are very rapid and very quick dissemination of the information. But because of this rapid and quick dissemination, what happens? We are stuck to the character, fitting the characters. So suppose there are a lot of public platforms like Instagram, Twitter, there space and algorithms are kept. And we have to fit into that character. Because of this and going on publicly, the information what we spread is very, very simplified. And as we simplify this information, it always misinterpreted. And oversimplification is always a problem. And this is what happens. The same thing happened in KEM some years back in the cath lab that stood in the neurosurgery department. And there was a hell in the public that the paralysis, stroke has been. So this is what happens. So what we think that the communication should be more realistic and it should be verified. The information given on these public platforms should be more scientifically based and should be in a particular, and the depth of that topic has to be given. So we have to be very careful while we are going on a public and while we are communicating with the patients and when we are on the open platforms. It's better we go on a more secure platform as compared to going on a open platform. That's what I think.
Thank you, sir. Now I would like to ask next question to Dr. Vidita Puri ma'am. How do you see social media evolving in the medical practice over the next few years?
I think I've already seen a huge change between when I started practice, like whatever, when I started my, when I became a doctor and now, and I'm seeing that the young, the young graduates and the young postgraduates are, even before they have finished with their post-graduation, are starting showing their presence in social media. So one of the biggest ones right now that I see is Instagram, at least in this segment. And though Instagram started as a photography, platform that people wanted to share their photographs, right now from what I'm seeing is that people are putting up clinical information. And it is to some extent, though one may cloak it in the form of an information to public, it is very much a subtle advertising. And this subtle advertising, I think, is going to go a long way towards their practice. In today's day and age where practice is really cutthroat and they do need to, everybody has to live and everybody has to make their money to keep their families. I think that these kind of social media platforms are positively going to have a positive impact. Everything has a positive and negative, but I think if it is done in a responsible manner and when it is done by professionals who know what they are talking about, it is going to have a positive change. So I think, yes, your question is basically, is there a change? I'm already seeing the change, and I think this change is exceedingly rapid.
Yes, true. Thank you, Vinita ma'am, for your view. In continuation with this, next question is to Dr. Shraddha. Being a favorite teacher for UGs at GS, what makes you different than others when it comes to teaching and using social media for the same? Perfect question for you, I think, Shraddha.
Yeah. Hi all. So thank you, Dr. Siddhi. Basically, I don't like monotony. That is something which I am. I like to be different on every days. So there were conventional teaching methods when I was a student, and this generation of Gen Zs and Gen Alpha, we can't use those conventional methods. We have to be different. Once I was traveling to Hampi with a group of almost age-wise, they were 20 to 30 years. So they were playing different games. And then I thought that why can't I apply these games to my teaching? And then when I started applying these games to medical teaching, I worked a lot on that. And I came up with 30 games for medical teaching for undergraduate and postgraduates, out of which I have a publications also for my game, which is a Super 30 game. So when I compared it, the conventional method of teaching and this method of teaching with gaming, there was a huge interest from students. There was a huge understanding before and after the game was done. So how social media helped me is because I was utilizing and playing these games with the KEM people. And then I started putting these games on the social media, Instagram, and I got responses from all over the Maharashtra and across India and out of India also. I should not take name of one country, so just which is next to us. And we got inquiries that can they come to us and learn. So we were little bit scared to get connected with them, but yes, we have connected globally because of these games which we have invented at GS, and that has really helped different type of teaching for students. So I am totally in for social media and gaming and teaching. Thank you.
Yeah, very interesting actually. Gaming in medicine really is very interesting. Shraddha, I have one more question for you in continuation with this. As a teacher and doctor, have you contributed to social media and what you have gained in returns?
Yeah, so the contribution of me to social media as a teacher, as I said, the games, the 30 games which I have invented, and I have conducted multiple workshops also for the same. Whereas as a doctor, what I have done is we have, as a part of the great institute of KEM, we have started doing multiple short films, patient education films, and we have almost finished with 12 of them out of 100. So we have published that as well, and we have got multiple responses from different patients that these are really amazing films and we should work more on that, because the films which we are putting, the content which we are giving is really scientific. That is very important when it comes to social media, as Vijay Singh sir also said, that it has to be filtered, it has to be scanned. So this is something which has helped the people to understand the disease in a better manner, in a real scientific manner, and in a simpler manner. And what social media has given to me, I think I have been invited as a TEDx speaker for after people went through my social media feeds. So I was a TEDx speaker last year for the time micromanagement, and I think happiness, that is what social media has given to me. Yeah, thank you.
Very good, very good. I feel social media is really empowering in this medical field.
So we have a new addition to the panel, and the addition is none other than our favorite Dean Madam, who has been really instrumental in bringing social media into KEM. Madam, I welcome you onto the panel. A big round of applause. I think KEM has a presence on social media thanks to Dean Madam's efforts and leadership.
Share your views about social media.
First of all, good morning to all of you, and welcome to the third day of our centenary celebrations. And I think we are doing fantastically well since last 2 days. And I think there are lots of people who are saying this, apart from those who are attending, all because of social media. So I think the first time I came to know about Instagram was in 2020. when my son was getting married and we went to all the fashion designers and we wanted to see their thing, they said, you have to see our product only on Instagram. So I told my would-be daughter-in-law, what is this Instagram? Till then I had no idea and I was never on social media, I was years together, Facebook, but never opened since years together. So after that, when I became, so I learned I had an account on Instagram, but when I joined as a dean, I realized that there are reporters, there are people who are always there to make news which are negative, positive. But somewhere when we are doing something good, why not boast about it? Why not tell media what we are doing? And that's the reason we said we will upgrade our website. And we also started the Instagram of KEM, LinkedIn of KEM, Facebook of KEM, and the YouTube channel of KEM. And I think that has really, really changed KEM face. In the beginning, I had to call the reporters, please come and do this news, come and attend this. Now it's the other way around. It is put up on the social media, on Instagram. They call me next day, madam, can we do the news on it? So the table is turned, because once we are on the social media, I think it really, KEM image is really uplifted after that. And the time I used to put in the night, before sleeping at 11:45, I used to go on the Instagram, add the pictures, put up the thing. So every night, I think the post used to come in the night, and and two things I used to go to do in the night before sleeping: order some online saris, and second is to put up on Instagram. So I think that both things, and I feel that social media really helps. Today also, I think we were not going to go live, but when I think CM sir was coming and it was decided that we have to have an internet live. So then we have got a YouTube link which is continuously streaming, and after that I've been getting lots and lots of, I think, positive response on the YouTube. Those who have not come are also able to see what our programs are and what level we have done it. So I feel it does have a negative impact sometimes, but what I do is I post, I never look at the comments. So I think that's the thing which you need to follow, because if you keep looking at the comments, I mean, it always, upsets you, or if someone has said this, someone has said that. I never look at the comments. And I think in last 6 months, I think Shraddha joined me for doing, and Sri Raj, both of them joined me actively to, upgrade our Instagram. And after that, I think our Instagram has reached to 6,000 followers, and our YouTube has more than 1,000 followers. So I think that's really commendable to all of them. So I just wanted to share this. And today we have again a big day. We have the big B of Bollywood coming today afternoon. Not afternoon, evening 6 p.m. And I'm sure we will be well behaved, and I think we should not have any towards incident, because that's one thing which we have to finish, and after that I think we'll be relieved that major things are over. Okay, thank you very much.
Thanks, ma'am, for your views. Next question is to Dr. Sriraj. Sriraj, you have been involved in handling the YouTube channel of KMH. How has this helped?
Yes. Thank you, Dr. Siddhi. So as Dean Madam rightly said, we are now at 1.2K followers, that is 1,200. And our live of day one had about 4,000 views total. And all good comments, all the orations had very good positive responses. And the Whistling Wood videos which we have made, GBS, dementia, stroke, and epilepsy, one of the videos has got 40,000 views. Imagine, all over. And as the handler of that channel, I get to see the analytics as well. And when I went to the analytics, all these views were mainly from age group above 50. So it has reached the perfect audience for these conditions. So that is what the algorithm actually does. Algorithm makes sure that the video reaches to the right person who is already searching such topics. So imagine someone who is searching about dementia or epilepsy, and then he sees, array, there is a video from KEM, which is one of the best hospitals. Then he clicks on that. So we are seeing that a lot of fake information is there. So to counter that, we actually need to step up our game and push better content. That fake, it's known as clickbait. So clickbaits work only for a short time. But when you have a good content, with very quality speakers and good information, the patient or the person sees that video for a longer time. And then that video gets pushed to more and more people. That is why we start getting more views after some time. It goes a bit like the bacterial curve. It's initially there is a bit of lag and then suddenly it picks up. That is only happens if your content is good. And with Whistling Woods, we are getting such quality content that our reputed institute video is being pushed over the ones who are probably unqualified to talk on that subject. So that is a very big thing, which is not just increasing our reach, and it is also leveling the playing field for the private clinicians as well. We have seen for years the stalwarts, they used to get patients on their own, but the new clinicians which come in the market, they probably need to do a lot more even if they might be good at it. So there is a level playing field now. They can put their videos on the social media and that passion is seen from the inside. You cannot fake the passion and love for the patients, right? What better example to show that it's a level playing field, that with all these stalwarts, you saw their CV. I am sitting right here with a CV almost next to zero. So I'm matching on the panel with such stalwarts. That itself is proof of the level playing field. Thank you.
I think about these films, no, I think the doctors and we have done the script writing. And our staff and doctors are the actors. So I think it's a new field where we can see that we are also good. And I think I never knew that I could do all this, but we have done this. So all 4 neurology films are like that. Vinitha has done plastic surgery films. So we have potential other than medicine also, and I think we must explore that.
Yes, ma'am. That's really been amazing what has happened now. Like we said that there are 2 sides to every coin. So my next question is to Dr. Anita Chalak, ma'am. So, ma'am, we're hearing a lot of good about social media, but do you feel that there are any ethical risks related to social media in healthcare?
Yes, thank you for that question. Yes, as she said, every coin has 2 sides. We are talking about good, everything good, but there are some serious ethical considerations with which we need to take care of. The first one being the breach of patients' confidentiality and privacy. Sharing patients' information, photographs, images without explicit consent, even unintentionally, can violate patients' privacy. Then there can be unverified data or unverified information which can mislead the patient, which can harm public trust. There can be conflict of interest, like if you, on social media, if you go on endorsing or promoting certain products, treatments, services, it may raise a question on your, you being biased or about having financial conflict of interest. There is also risk of cyber security and data risk, and we as health professionals, we are exposed to that too, which again compromises the objectivity of the profession. And more importantly, it also deals with emotions of patient. If you are in a public forum, if you are discussing a patient's treatment, patient's conditions, patient's experiences, it may stigmatize the patient, it may embarrass the patient, and patient may get exploited. That is another risk. And becoming friendly with patient, too much friendly with patient, following your patients, blurs the line between the professional and personal relationships. There also we need to take care of. And finally, the legal regulations. If we fail to, if there is failure to comply in regulations and the guidelines regarding the patient consent, regarding the advertising, it may lead to lawsuits or serious punishments also. So yes, we need to consider all these points seriously. Yeah.
Right, very true, madam. This answer has been very comprehensive. So I think it has answered our next question also. So I think we can go on to the question after that. So this question is already answered. So we can go on to the next question. So Dr. Balaji, do you feel, now madam has said that there can be problems related to informed consent and confidentiality. So how do you think we can minimize this harm?
Yeah, she has answered a lot of, answered this question actually. But what I feel is that there should be a clear-cut demarcation or clear-cut distinguishing factors between the professionals and the patients. They should mark a border between them. And when we are spreading or when we are putting information on the public platforms, I again say that the data or the information should be more verified, more scientific, and there shouldn't be any conflict of interest. For example, we can't utter the name of the companies, pharmacies, or the drug using the trade names. For example, we have warfarin, patients on warfarin. There was one controversy in the media that what was the INR? The INR also stands for Indian currency rupees. So it created a problem in the media that INR, patients INR was some 5 or 6. Then it went in some another perspective. That was misinterpreted completely. So we have to be very careful. We have to be very cautious about putting on the information, and we have to be very categorically see the characteristics and the clipettes what he has told. We have to be in a specific platform for that. So we have to verify our data before presenting, and we have to be careful of patients' privacy, patients' personal aspects. We can't reveal the case scenarios or the patient. We can't breach their confidentiality. So we have to, and also plus the training of the professionals is very important. They have to be trained for that, what kind of matter he has to be put on the social platforms or the public platforms, where it's open system. So it's rather than going to open system, go to a closed and a secure system, because in open system your data might be hacked also. We have to be very careful about the cyber crime. So we need to restrict the data, we need to restrict the information. It has to be with the point, depth, and scientifically based.
Thank you, sir. This is very interesting. And our next question is to Dr. Sriraj. Sriraj, can you share your views on how social media should be used to combat health misinformation?
Yes, so like Dr. Balaji rightly said, lots of misinformation is there, but again, all the social media apps, they offer services of being verified. So you get a blue tick around your account, and once the patient sees that on the same topic, there is some institute which has a verified claim is offering on the same topic, like just for example, we will take epilepsy again. If I have 2 videos, one on epilepsy by some person, random person, and I have a video on epilepsy by KEM, then as a patient or as a person watching as an audience, I am more likely to click on that blue tick wala page and then listen to the real expert. So we all have been victims of misinformation. On WhatsApp, there is literally a video which says blood pressure kam karne ke liye prick your finger and let the blood ooze and so on and so forth. But when we as professionals spread that information, the right information to counter that, then it becomes more trustworthy. If I am sharing to my relatives the video about actual hypertension, then they will realize, yes, he is from KEM, he is saying the right thing. So rather than spreading that needle prick wala video, I will spread this video instead, which is from a good institute and a verified tag. So it is next to impossible. To be very honest, you cannot combat health misinformation, because by the time we put one verified video, hundreds of unverified content is already there.
Yes.
Even with fields like dermatology and nutrition, etc., you are saying anyone comes and gives advice on protein, this, that. But if we stop, then that is only going to increase. So we have to take that minimum effort. It just takes few seconds to spread the right content on our WhatsApp status or on wherever you are. You put our official videos on our WhatsApp status or any group in which you get a unverified or a unscientifical video, you immediately put our content which is related to topic and say, see, this whatever you have shared is wrong. This is the actual thing. COVID does not spread like this. See this video from AIMS or see this video from KEM about COVID, which is by experts of COVID. COVID vaccine does not cause XYZ because KEM doctors are saying this. So that gets multiplied in a way the persons, the users now are sharing our content, which is now replacing that unverified content. So unless we do that, like our body's immunity is going down, that doesn't mean we just give up. Because so much of unverified claims are going on, we have to step up, the professionals have to step up in making sure that the verified videos are pushed more and more. So I request all of us to share our videos as well on your social media platforms. Thank you so much.
Yes, agree with you, Sriraj. Next question to respected Dean Madam. So can social media empower patients to take a more active role in their healthcare decisions? What is your opinion, ma'am?
I think definitely, because I have seen that when we started a comprehensive epilepsy care center, I just called someone and did my video on giving what is epilepsy surgery, and after that we had lots and lots of patients. After listening to that video, they will come for epilepsy surgery, and I had done it because the global wanted, but then I never realized that it will have so much impact. So then patients who couldn't afford were operated at KEM and others at global. So definitely it does make, after the stroke film I think, and even before when I think Uddhav Thackeray came to inaugurate the stroke session, after that speech and whole thing was, then many people came to know that there is a golden hour, something like that in the stroke, and we have to rush to the near stroke care hospital and do something good. So definitely it does make a difference to the patients if they know what is the importance and how soon should they go to the hospital and whom they should go to. So, you know, like epilepsy can be treated by the general neurologist also, but when it is uncontrolled, it should be sent to a center where we can think of a surgery, because it cannot be done. So this information, if often the general neurologist may not give it to the patient. So often it has happened that patient come themselves while listening to this, can we undergo this? And some of them are not, but we at least have a option that they have a cure which they know, they can ask for it. So I think same is in the stroke, I think. So in many, I think they do change their aspect. And
yes, perfect.
In continuation with this, Madam Puri Madam, what is your opinion regarding how can we facilitate this empowerment while ensuring that our patients are guided correctly? Madam has given her...
Yeah, so I think Dr. Balaji has also mentioned a lot about this. When we say how do we empower ourselves, I think the best way is for us as clinicians to understand how to put out the content that we put out. Having guidance on how to do that would be great. As plastic surgeons, there's a lot of, I'm seeing that the young consultants are putting out a lot of stuff on, let us say, liposuction or how to shape your, the nose or your cheeks or things like that. So if done well, there's no problem. But I have seen a few videos, let us say, by some younger consultants on rhinoplasty where the patient's face is also seen. They may have taken a consent at that time, but one needs to be exceedingly sure that, 2 years down the line, they don't turn around and actually, start being harmful towards the doctor. We have an incident which has happened, and this is way before this very big boom of so much happening online. On Facebook, one of the boys, in fact, they had done, he'd learned some burns here and he had not learned burns elsewhere. So when he finally saved a 60% burns in private practice, he went and put it up on his Facebook account. There were very beautiful photographs of him with the patient. And then there, I guess, there is that little bit of blurring of the patient-doctor relationship. I thought it was okay. But some arbitrary person online decided that they would put a complaint to MMC about him. Now, I think we have to understand that social media is here to stay. So if we have so much of positive about it, there will positively be negative. So if we want our presence on social media, not only do we have to be balanced, like Madam said something very nice. She said, I spend a little bit of time. So we cannot be consumed by this whole social media and we cannot be all the time on it. Similarly, take your time out, be sure that you are informed what you want to put in it, and then accept the criticism when it happens, because that frankly is not that much under our control, So we have to empower ourselves. I think probably in conferences we should start having a session like in our conferences, we always have a session on medico-legal aspects. So we probably now need to start and that's very, so medico-legal aspects and how to, your financial aspects, where to put your money. It just means that people have a lot of money. But I think the third thing that now we need to essentially have is a symposium on how to handle your social media accounts. Along with that, how to handle if it goes viral or if there are negative comments.
It's really a very good suggestion, madam. Our next question is to Dr. Singh. Considering, sir, your vast experience in the community medicine, and since you are a public health expert, can you please give an overview of role of social media used in field of public health and challenges?
Thank you very much for this nice question. Everybody has witnessed COVID-19, the role of
Yes,
WHO,
sir, yes.
role of other health agencies. And I am happy that through this social media like Facebook and Twitter, we could reach to the wide population, the whole world. And WHO, UNICEF, they are using these such social medias for creating health awareness. Even in national level, we have many, WHO created global e-health strategy where these medias are used for different health awareness programs. In India, we have hashtag like TB Harega, Bharat Jeetega, Poshan Abhiyan, and then Ayushman Bharat is very important where we are connecting the stakeholder with the health system. So it is very important to connect the ground root people, ground level people with the health system. Now, definitely, I appreciate and I'm very happy that I'm a part of KM Institute, that we have made so many of short films, which now going directly to the people, and they are creating so much of awareness. And coming to the second question, which Madam has answered, but I want to add to it that along with this, games and all which Dr. Shraddha was talking about, that innovative techniques, okay. Along with this, there are a lot of other challenges which we are actually facing, our children are facing, like suppose one game she puts in, like, so related games will spurt inside immediately. So the students' attention get diverted. So we have to very careful whenever you are putting anything. So because our media is free, but this is heavily loaded by the advertisement and the people who are want to. So similar things they come in between. That is what we have experienced in COVID-19 is the doctors individually they used to put their opinions without standardization. So in KM which we are putting, things are standardized. So we have to see that whenever we are putting, it should be properly referenced, properly standardized, then only we can put. I think with social media, we can reach to wide area, and we could achieve, and we are achieving, the public health awareness in relation to many of the programs. Thank you.
Thank you, sir. You are very well explained, journalists. Can you just the previous question?
Thank you, sir. Thank you, Dean Madam, for being here on the stage. I think the next question we can ask Anita Madam. So, Madam, do you feel that medical schools can integrate social media in their curriculum? And if yes, do you feel there are advantages and disadvantages of this initiative?
So, yes, if done thoughtfully, social media can be integrated for the medical curriculum for medical students. Like the platforms like LinkedIn, Twitter, ResearchGate helps medical student to get connected with the mentors, the experts, the peers. Platforms like Reddit, if you have heard about it, Reddit uses the clinical cases, anonymized cases, to teach diagnostic skill and clinical reasoning skills. Platforms like PubMed Alert
it helps or it encourages the student to stay updated about the recent advancement, medical advancement and the recent trends going on in healthcare. We have a lot of talk on Instagrams and YouTube. We are generating a lot of content, educational content. So it empowers students to develop educational contents. There are certain virtual simulation tools available which gives very enriching and enriching learning in the form of virtual surgeries. So yes, it is useful. Even WhatsApp, Discord helps people sharing their knowledge and keeping connected. Platforms like Facebook will help in, if you want to have some health campaign, it will teach the learners how to put the medical information or how to communicate the medical information with public. And finally, the blogs and the LinkedIn articles help students to reflect on their own learning and keep a track on their own professional success, I can say. So yes, this can very well, if done thoughtfully, it can be integrated. Thank you.
Yes, very good, ma'am. Thank you. Next question is to Dr. Balaji. Balaji, sir, could you share your views on whether social media can replace traditional doctor-patient communication?
No, social media cannot and should not replace. And it has never to be done because our healthcare system, the integrity of the healthcare system lies in one-to-one and personal relationship with the patient and the professional. If there is no one-to-one relationship, if there is no compassion, empathy, and if you don't know the details of the patient, then it's impossible to maintain the relationship. So we have, and social media, it's very difficult. We can't be public always with patient's condition and patient details or personal aspects. So it has should never change, and it should always integrate between the patient, and there should be a quality time between the patient and the professional, and so that we can understand the patient. And I think so only the communication and the feeling and the touch that ultimately 90% heals the patient rather than the complete treatment. The treatment part acts as a placebo in some patient, and it only acts for some specific diagnosis. So we should be always in communication with the patients, and one-to-one communication is always the best.
Very true.
Shilpashri, I want to add something to this, and this is for all those people on the back benches, the black seats. Okay, this is for you. On the first day, we had an amazing oration by Dr. Udwadia. Those of you who were not here, I would suggest that do listen to him. And this is the exact thing what he spoke about. He may have, of the whole oration, he probably spent 10 minutes speaking about this. And he, of course, has this amazing way with words, so you will also enjoy the way he spoke. But that is what he talks about. He says social media cannot take history, right? Social media cannot pass on this empathy. And we as, he says we need to bring our, sadly, this is the word he used, he said there's hubris. We are also sure about ourselves that we are not able to open up even to some methods, maybe traditional methods, or even this feeling that faith can heal. It is faith in a doctor. So that will happen only if you are face to face. As Madam mentioned, all of this is on YouTube. So may I suggest that all of you do hear this oration of Dr. Udwadia. It is surely going to enrich everybody's life. And it says what Dr. Balaji just mentioned. A doctor-patient relationship, which is face-to-face, is very different from an online consult.
So everyone is for the one-to-one relationship that the patient has with the doctor, that the doctor also shares with the patient. So next question to Dr. Sriraj. How can healthcare professionals use social media to build their personal or institutional brand?
Yes, so again the same thing, it is levels the playing field, so you are actually matching the stalwarts in their field by using social media and with good quality content. See, basically in the private practice there is something known as PR officer who goes and sees asks the family physicians to refer patients to you, right? So there is some kind of dichotomy in that practice as well. So here you are reaching out to the patients directly using the social media to develop your own brand, or in our case, the KEM brand, that is the institution's brand. So if you see, all the major institutes across India have already put up so much of content, and now we have also started putting this wonderful videos which are getting views increasingly. It's undergoing a logarithmic increase. In the last few videos, we have got lots and lots of views. So as healthcare professional, it adds to more visibility to yourself. There are so many of us in not just the faculty, also nursing, etc., who are doing such a good work. They are seeing thousands of patients daily, but they are not visible at all. But with the videos we have posted, their faces are being seen by 50,000, 1 lakh people, a nurse or a ward boy in KEM, and we are taking them as actors as well. And they are showing it so enthusiastically to their relatives. He has been serving for 20 years in KEM, and almost there was no appreciation from the people that this person is working so hard and doing night duties. Now he is enthusiastically sharing to each and every individual that yes, my KEM is doing such great work, and that is how the institute's name is also going to build up much beyond Maharashtra, even India, and maybe even globally. So building a brand in this era has to depend on social media. It is, like Sir rightly said, we have to understand it's not a substitute. Our core healthcare will remain the same, but it has to be supplemented with social media. We cannot lose one-on-one interaction with the patient. Having said that, someone in a rural area is looking at KEM's video. He may never get the chance in his lifetime to visit Mumbai and KEM. 1,000 kilometers away also he is learning about our topics, hypertension, dementia, GBS, which he might not even heard, but someone might have expired and they missed the diagnosis completely. And some doctor sitting in the rural area has seen that video. It is going to, next time he sees a similar case of paralysis, he will think, "Arey, why can't this not be GBS?" So that is the amount of reach we are getting now with social media. And in teaching also, I'd like to add to point of Anita ma'am, I use my YouTube concept to teach the students. So in YouTube, basically, the first few minutes of your video is very important. So you need to start with a hook to grab the audience. So whenever I start with my lectures, I generally put a joke or meme right at the front. So students, as it is, we are getting very less attendance, 30%. So what are few students who are sitting, they immediately look up, "Arey, kya, kaun hai jo aise sikha raha hai?" You know, jokes and all. So then I continue with our conventional teaching. But that initial part gets them attracted, and then they will watch to your whole lecture with much more interest. If I can give simple examples, there is a medium in microbiology known as NNN medium. So what I did was just put up a photo of Neil Nitin Mukesh and then said, ki, just remember when you are asked about medium for Leishmania, you can see the, remember Neil Nitin Mukesh, and then that adds to the retention. And by chance that comes as an MCQ in your NEET exams or entrance exam, your rank might go shoot up just because of one good answer. Similar examples I can give is for autoimmunity. I had shown, if you know Marvel, Hulk beating up Thor, which is his own team member. So your own cells are beating your own partners. That was one example. Then hypersensitivity, Hulk beats up a villain in which their own floor gets crushed. So that is your body reacting exaggerately, and your own body got damaged in the process of fighting with the villain. So this is some techniques we can use, and students really like it. And when I post it on Twitter, students from across India are actually appreciating, not just KEM. So the reach and the brand goes beyond our limited scope, which the physical world does not offer. Thank you.
That's very nice. In fact, you are using innovative teaching strategies, and you're using social media to help you use these innovative teaching strategies. So that's really nice. I think we're running a bit short of time. So the next question is for Dr. Shraddha.
Next question is for Dr. Shraddha. Shraddha, being a podcaster and face of KEM social media, tell us how it has strengthened the intra and interstitial level connect.
Yeah, so as a part of medicine department, I was communicating mainly to the people of medicine department. But once we started for the filming, and when I started connecting with different department people, that has really strengthened my network. I had never met, Chetan Kantharia sir, or a blood bank HOD, or transfusion medicine HOD, Jayashree Sharma madam. And after meeting them and after communicating with them for different purposes, it not only strengthened my network with them, but also I learned so many things other than medicine. So when I was doing, for example, when I was doing a session with for our new pain OT, and I really learned that there are these treatments which are also available, which I was not knowing as a physician. So you continue to learn when you connect with different departments. So what I feel is how we can apply this, because I am a part of a social media team, and that is why maybe I can connect with different people of different department. But is it possible for those faculties to connect with different department even if they are not a part of the social media team? That is the question. Absolutely yes. So we can do a interdepartmental level, some podcast or some meets, and we have a podcast room now, and thanks to our dean madam for that. And let's connect 2-3 departments sitting together, talking on one topic, giving their views, and that is how I feel that we can strengthen our connect at intra-department and at inter-department level. So let's use our podcast room. It's at ground floor college building where the telemedicine office used to be there, and we have all the AV facilities available. So please, I request all the faculties and students across the entire GSMC KEMH to take up this facility, use it, and let's strengthen our KEM globally. Thank you.
Thank you, Dr. Shraddha. Now, a quick last closing thought by each of our panelists. Yes, Anita madam.
So, a lot have been discussed about, good things about social media and bad things about social media. I was discussing with Vinita Puri madam, and she said what I wanted to say. There should be a balance. Yes, we need stricter regulations for this, but there has to be a balance to, curb the, you can say, spread of unverified data, or ensure patient privacy, and to have more accountability. There has to be some balance, and I feel these regulatory frameworks are lagging behind technology. Right. And we need some technology which goes with, which evolves with, we need some regulations which evolves with technology and as per the societal needs. So this is my view.
Thank you, madam. Sir?
Yeah, the things are very clear now. So we have to use the social media with caution. But only one thing I want to share with everyone, which I am very happy to announce, that besides our innovative techniques, we in our department, in KM Hospital, we have yellow fever OPD, where we get lot of inquiries. And so with the permission of madam and also approval of dean madam, we have willing to start, or we have proposed to start chatbots for our OPD. So that will come in our website of KM, so that anybody can visit and see. And for this, I am too much thankful for madam that she has approved this, and that she has approved in the centenary year. So that is very good for us, and there won't be any calls to my cabin directly from patients to inquire about timings and also detail about yellow fever vaccination. So thank you very much, madam.
Thank you
so
sir.
much.
That's an excellent initiative. Balaji sir?
Yeah, social media, nowadays these digital platforms also, they are meant only for commercialization. They are using professionals as a providers rather than the doctors or healing doctors. So it has to be curtailed on that. There should be a specific limitations. There shouldn't be a 3-star, 4-star professionals, and these algorithms and star ratings should be curtailed down, and there should be a face-to-face quality time with the patient. What I feel is face-to-face and quality time with the patient is most important. Thank you.
Thank you. We're really running short of time, so can we have single thoughts? Yes, Dr. Sriraj.
So I have only I have only one advice, one to the students. I see a lot of students posting stuff on social media like Anita ma'am rightly said. So make sure you maintain the confidentiality of the patient and privacy of the patient, and before hitting the send button to that particular app, just pause for 10 seconds and ask yourself, ये सचमुच social media पे जाना चाहिए क्या? If it is not adding any value, then just don't put it. If it is just about your personal achievement, yes, if you are feeling good about it, you want to put, make sure the patient's face is covered, and you put. Many interns also put that, right? So just ask yourself, ये सच में जाना चाहिए क्या, तो ही डालना है. And second advice for the faculty and the other experts of the subject, before hitting send, just go through whatever we have written, whether it is a text post, and just see for any factual or scientific slight deviation from the science that we have to go. That as a personal practice I follow, I read my whole post once again, because there are so many just waiting for just a small slip up to pounce on us कि अरे इसने ऐसे कैसे बोला कि COVID ऐसा है वैसा है. It might be just slight deviation, but then I re-go through my stuff and then only click on the send button.
Thank you. Puri ma'am.
Social media is here to stay, and just like when cars probably came to the road, there may have been similar discussions. Should we really have cars on the road because we're going to have accidents? There are regulations, and we have faster and faster cars on the road. Similarly, there can be regulations, but you can navigate this very safely by empowering yourself and also having a balance in life about what you do, and not have really pride that today just because of your videos you are getting 20 patients. But remember that you yourself as a young clinician have a certain learning curve, and even if the senior surgeon is now getting lesser patients as compared to you, remember that you have a learning curve and that you have your responsibility towards your patients.
Thank you.
A very famous quote from Robin Sharma's book, The 5M Club, and that is, technology should be your servant, not your master. Apply the same thing to social media. That's it. Enjoy
That's
it.
so aptly said. Thank you, everyone. So, in today's panel discussion, we've heard about trends, we've heard about opportunities, we've heard about challenges, and like Madam said, we know that social media is here to stay. It is up to us as to how responsibly we use it, because we are going to plunge deeply into it. So I think the onus is on us as to how we use it rightly. Thank you very much, all of you, for being here. A big round of applause.
Thank you, respected dignitaries on the dais and the moderators, for such a wonderful discussion. Thank you, Dean ma'am, for your valuable inputs about the social media. I would like to request Dr. Siddhi Chikhalkar ma'am to felicitate Dr. Vinita Puri ma'am. I would like to request Dr. Siddhi Chikhalkar ma'am to felicitate Shraddha More. I would like to request Siddhi ma'am to felicitate Dr. Sriraj. I request Dr. Shilpashri ma'am to felicitate Dr. Balaji Aironi sir. I request Dr. Shilpashri ma'am to felicitate Dr. Vijay Kumar Singh sir. I request Dr. Shilpashri ma'am to felicitate Dr. Anita Chalak ma'am. Thank you all dignitaries on the dais. So here we are concluding the panel discussion on social media, which have become essential tools for personal connections, networking and exchange of ideas. Now I request Dr. Urvashi to take over for the further next discussion, that is role of AI in clinical practice. Thank you.
Thank you, Dr. Sikandar Banu. Good morning, everyone. I'm Dr. Urvashi Parmar, Associate Professor from the Department of Pharmacology and Therapeutics. The second panel discussion is the role of AI in clinical practice. Artificial intelligence is gaining importance in medicine these days. It helps in improving diagnosis, reduces error by interpreting various tests, saves time, improves patient care, and reduces the cost. At the same time, AI may pose a threat to ethics, security, and patient privacy. For this panel discussion, I would first like to introduce our first moderator, Dr. Pallavi Surase, Professor Additional from the Department of Microbiology. She has more than 18 years of experience and has many publications to her credit. She is a recipient of 3 research awards. Her areas of interest are in microbiology and mycology. The second moderator for this session is Dr. Deepika Sadavarte, Assistant Professor in the Department of Community Medicine. She is an avid researcher with more than 30 publications to her credit. She is a recipient of Dr. Chandrakant Patil Memorial Certificate Award. She is also a recipient of Dr. Prabhakar Rege and Mrs. Rekha Rege Institution Award for standing first in MD exams in community medicine. Her areas of interest are maternal and child health, travel medicine, and adult immunization. Please give a warm welcome to Dr. Pallavi and Dr. Deepika.
Good morning everyone. Myself Dr. Pallavi Surase, Professor Additional in the Department of Microbiology. I would like to thank Staff Society for giving me this opportunity as a moderator for this session, that is the role of AI in clinical practice. Artificial intelligence in healthcare represents transformative leap in a medical service are delivered, diagnosed and managed. These technologies are designed to mimic human intelligence and can analyze large volume of data, making them incredibly effective in diagnosing diseases, recommending treatments and improving operational efficiency. Despite its many advantages of AI, it also raises concerns and challenges such as issues related to bias, data privacy, security, and job replacement, and also it can be misused. As these technologies continue to evolve and integrate into everyday life, understanding its potential implications become increasingly critical for society. So let's have new insights from our eminent panelists. I would like to call our panelists for the panel discussion of role of AI in healthcare practice. So I would like to call Dr. Uday Jadhav sir. He is a professor and head Department of CVTS. He has 160 publications and 126 presentations and numerous awards to his credits. His area of interest are coronary bypass surgery, minimal invasive surgery, lung surgery and transplant surgery. Please welcome sir on the dais.
Our next panelist is Dr. Jignesh Gandhi sir. He is professor and unit head, Department of Surgery. He is also honorary consultant at Fortis and Gleneagles Hospital, author to numerous articles in reputable journals, 100+ presentations. He is the founder of AI company called Arista Surge, first prize, a gold medal in MS surgery in 1998. His areas of interest being robotic surgery, hepatobiliary and advanced laparoscopic surgery, abdominal wall reconstruction. We welcome you, sir.
So the next panelist is Dr. Neeraj Jain. He is in professor and head Department of Neurology in our own hospital, consultant neurologist to Apollo Hospital, New Mumbai. He has 35 publications and 20 presentations, and he's been awarded as a traveling fellowship bursary for AOMC in 2009. His area of interest is epilepsy, EEG and neuromuscular diseases. Please welcome sir.
Our next panelist is Dr. Amla Kudarkar Madam, Professor and Head Department of Anesthesia. She has 31 publications and 200+ presentations. She is President of ISA Mumbai Metro, co-editor of book Practical Approach to Anesthesia for Emergency Surgical Procedures. Her areas of interest being difficult airway, bariatric surgery and critical care. We welcome you, ma'am.
The next panelist is our own senior sir, Dr. Shubhranshu Mohanty sir. He is a professor in Department of Orthopedics, KM Hospital, and also honorary consultant arthroplasty surgeon in Jaslok Hospital. He has many more publications, 128 publications and 31 book chapters. He has done many presentations in different seminar conferences. He's been awarded as a president in Indian Arthroplasty Association and also Bombay Orthopedic Society. He is an education and fellowship chairperson in Indian Society of Knee Surgeons. Actually, he has been awarded so many, I can see the list of honors and achievements of the sir, but not the least is he's been awarded as a Silver Jubilee Oration in Madhya Pradesh Orthopedic Society. His keen area of interest are primary and revision hip and knee joint replacement, management of infected joint replacement, robotic assistant joint replacement, orthopedic management in hemophilia. Please welcome sir on the dais.
Our last panelist for this panel discussion, Dr. Ravindra Devkar sir. He is professor additional in Department of Forensic Medicine, a Senate member of MUHS Nashik, editor-in-chief of Journal of Forensic Medicine, Science and Law. He has 55 publications and more than 20 presentations. He's been awarded appreciation by Medical Legal Association of Maharashtra for noteworthy work in forensic medicine. Areas of interest being forensic radiology, forensic criminology, clinical toxicology, clinical forensic medicine. We welcome all the panelists.
Hello.
So without wasting time, I will start the panel discussion. And the first question I want to ask Dr. Uday Jadhav, sir. Sir, how is AI harnessed in clinical practice? Can you give us some examples where it's been used?
Good morning, everybody, and a warm welcome to all of us. And thanks, madam. I think it is a very important question, basically, in our day-to-day clinical practice. When I look towards artificial intelligence and a physician, so today we physicians, we are in very, very difficult and different scenarios. The most important aspect is our patient and doctor relationship. So we have to be with advanced technologies. The technology is going to boom. It will take all the advanced wings and go ahead. Now, we are in an era of smart physician and a smart patient. So, using this technology and using it smartly. So, that's where today what we have to manage most is the time management, basically. The quality time which I spend with my patient, the interaction which I have with my patient, it cannot be backseated. And the amount of time which a physician is spending in analyzing data, collecting history, and coming to an accurate diagnosis, it has to be a pinpoint. Now we are heading towards medical diseases which require immediate diagnosis and immediate treatment, like in neurology, stroke, like in cardiology, myocardial infarctions, abnormalities of the ECGs. Then these conditions are there which require timely intervention. Otherwise, it can lead to a morbid human being which will be very difficult to manage. So this will be done very effectively by using artificial intelligence in clinical practice. They are not here to replace us. We should not be afraid about that, because they have been generated by human mind and human intelligence. They will be like our assistants, rather smart assistants, which will help us in assimilating data, providing immediate information before the patient comes, helping in triage. Then, as we see, where it helps us, like in a critical care unit, we have multiple patients with multiple ailments. Immediately you can assimilate, use the AI intelligence, the data, it will help you to segregate the patients. It can even interpret this patient is landing towards a septic shock. Before the patient goes in septic shock, you can analyze it, give him proper treatment. Then, like in patient-controlled analgesia, like we use opioid following our operations for pain relief, it can give me a clinical data on which I can interpret that this can lead to opioid dependence in that patient. And before he becomes opioid dependence, I can immediately shift my focus and try another analgesics, and so we can minimize the problem basically, and it will make a doctor and the patient interaction very effective. Secondly, as we look towards India, the health sector, our literacy rate. So if you go through Google and search, one is progress basically, and second is the reality. So we stand in the World Forum in our literacy for basic education. It is around, we are at 128 number. Countries like Korea, Greenland, even the neighboring country like China, they are approaching, or Japan, they are approaching 99.1% to 99.2%. So in this part where we are living, we can incorporate artificial intelligence, go to the remotest of the remote areas, the people who are underprivileged, we can use this technology because it will become cost effective. So there are multiple facets basically, and we have to approach and embrace this technology in an effective way. Thank you, madam.
Thank you, sir. Thank you for such a informative input. What I liked is AI cannot replace humans, and it can help to better patient management. Thank you, sir. The next question.
Next question I would like to ask to Jag sir, as we rightly call him. So, sir, being a UG student from here, I've seen you performing surgeries for past more than 25 years. And I would like to ask you, sir, what are the benefits of AI in the clinical practice? Like, you have been performing surgeries. So, can you share your experience with AI in surgical field?
Good morning, everybody, and first of all, thanks to the panelists and Dean Madam for getting me here for this meeting. At the outset, let me tell you, artificial intelligence is here to stay. That's for sure. So we have to make it as a friend. As a surgeon, if you ask me, artificial intelligence has helped me from pre-operative planning. So when I'm seeing a patient, today with the data, we can predict that what should be the right treatment for the patient. The second is, it also helps us to identify what is the right investigation, because today if you see, investigations can be across. You can have a scan or an MR or so many things. But if you have a prediction, then you can find out that if this patient has got these symptoms, maybe today the CT scan is the best for him. So it helps me there. Intraoperatively, today as a surgeon, it has helped me a lot in robotic procedures, because what has happened is, we can predict certain steps of the operation and can come to a proper algorithm in which we can have a safe outcome for the patient. So pre-operatively, intraoperatively, post-operatively, it has helped me as a surgeon in predicting which patients of mine will be an outlier from a standard of care. And along with that, to my administrative staff. So in a hospital like ours, where we have so much of surgical data, what will happen is, if we try to feed in a lot of data, because AI is data hungry, what will happen is we will be in a position to develop algorithm pools for commonest problems which we see in our institution. And finally, as a surgeon, it has helped me as a teacher, because my undergraduate and postgraduate students today, with augmented reality, virtual reality, which is a part of the AI, my teaching modules are getting more finer. So what is happening is the backbone of an institution, which are the UG and the PG students, will get trained better if we start incorporating AI into our clinical practice. Thank you.
So as rightly said by you, sir, even in schools, like we have starting using AI even in schools. So I think medical schools are also,
Absolutely.
getting AI day by day.
Absolutely,
Yeah,
yeah.
it's increasing.
Well said.
Yes.
Thank you.
Thank you, sir.
So my next question is to Dr. Neeraj Jain, sir. Sir, are there any standards or guidelines available for use of AI and any monitoring mechanisms for AI?
So I think it's a very relevant question in this discussion. So as such, there are no federal laws for use of AI in healthcare as of now. But there are various guidelines which are available. And why guidelines are important? Because AI can be mischievous sometimes. For example, if I see a stroke patient and we do a CT scan, which can be normal in acute stage. Now a stroke mimic can be misleading, because person can have a stroke mimic. So you might be caught in the legal proceedings. So that's why the regulations are very, very important. Now to come to the guidelines, US FDA recognizes AI as a medical device. So the laws and regulations which are related to any particular device or a software pertains to the AI as well. In European countries, there is a EU AI Act which governs the use of AI in healthcare settings and which has components of transparency, which has components of ethics for use in the patient care. In India, we have limited regulations. There is no law, but then ICMR has definitely proposed a lot of guidelines in 2023, and it encompasses use of AI in the healthcare settings, and especially concentrates on the privacy and the rights of the patient, and to be transparent to whatever the AI has its role. The second thing important is that AI is ever evolving. So the more the data you feed, the more information or more robust the AI output becomes. So the guidelines have to evolve very rapidly. So presently guidelines are based on the review of the literature and the present status of our medical knowledge. But the AI knowledge is evolving every year. So the guidelines have to be rapidly corrected according to the years and years. So I think regulations are very, very important, and in coming time we would have robust regulations for use of AI in healthcare.
So just for that, a little bit of inside information. Just 2 weeks back, there's a high-level meeting which has happened because one of my partner who works with us, Dr. Kshitij, who is also a part of IIT Mumbai and ex-alumni of KEM, he's also involved in that. So we are coming out with a white paper soon on AI. So the government of India is also looking very aggressively. This meeting has just happened about 2 weeks back. So maybe soon we will have a white paper on this, and all of us will be also under regulation.
I think even WHO has come up with the data privacy and security medical device guidelines. Thank you, sir. Thank you for your valuable input.
My next question is to Dr. Amla, ma'am. Ma'am, when we talk about AI, obviously there are, as every coin has two sides. Some people accept it, some people are, they have resistance towards it. So what are your views about acceptance and resistance towards adoption of AI in healthcare setting?
As I was going through literature regarding this, there are many articles, and most of these are based on the interviews either in person or telephonic and questionnaire based. So the result of this reveals that almost 70 to 80% of us, they are very positive about the use of AI in healthcare. Because they see that it has definitely a role and it is the thing of future, and that all of us must get trained in that. However, when it comes to actual setting, in the practical setting, very few of us have really, have accepted this as a technology. I mean, very few, like Jignesh and all, they have gone all over and got them upskilled in this. But still, many are a little reluctant. And why that is so is because we are worried about the data secrecy, maintaining the data secrecy. We fear that our data will be, exposed to the world and it can be malutilized. Second is, as a human nature, many of us just resist change. We are happy in our cozy whatever, jaise the, that attitude. So you require really efforts to get yourself trained. There is always a fear about the cost that is involved, which may not be possible in all the settings. So that is another factor, And many of us, I mean, I consider now, I may be considered by others as old timers. So we are still, we want that patient connect. Everything cannot be left to AI. So we do value the patient and doctor connection. Another fear is we might de-skill ourselves. For example, just to give an example about AI in anesthesia. Now, USG, most of the nerve blocks that we carry, they are ultrasonographic guided. So you see the vessel, you see the nerve, and there you can go and give the block. Now, with the use of AI in this technology, the nerve becomes yellow, the artery becomes red, and the vein becomes blue. Now, 10 years down the line, our residents may not know, unless they see the color, they may not be able to identify. So somewhere that clinical acumen we may lose. I don't know what is going to happen, but that is also fear. So these are various aspects for which there is reluctance, and I think mostly it is data and cost that are involved.
Very rightly said, ma'am. And I think we all will agree that AI is there to help us and not replace us.
So my next question is to Mohanty sir. Sir, can you just, what will be the impact of AI on medical decision-making capacity and skills of clinical practice professionals?
Okay, good morning. Thank you, Staff Society, for the opportunity. My learned friends have told, about the value of AI in day-to-day practice or, in future also. But friends, what I would suggest that gradually what Amla Madam told, we are losing our acumen for the clinical diagnosis as well as the therapeutics. For example, you see, I'll quote of course Dr. Udwadia what he was telling that day. Previously it was the patient and the doctor and the relationship between the patient and the doctor. But now there is a machine standing between the patient and the doctor. And that's why the doctors are getting influenced by the machine, in diagnosing or in treating that particular patient. For example, I'll tell, of course, I'm an orthopedic surgeon, so I'll tell some orthopedic examples. You see a patient, you take the history and then you think about some diagnosis, then you investigate that patient to arrive at a final diagnosis. But unfortunately, you just listen the history, suppose there's a backache, and then advise MRI, and MRI will show a disc bulge, and immediately you tell the patient for a surgery for the disc bulge. It's not the way. So you have to correlate your clinical findings with the investigations. Suppose you are 8 people sitting here. If you do MRI of 8 people, you will say 6 out of us will have some kind of disc bulge, some kind of degenerative changes in the spine. That doesn't mean that it requires a treatment. You have to have a clinical acumen to judge the patient, listen to the symptoms, examine, elicit the clinical findings, whether that is correlating with the MRI findings. Then only you will operate so that the patient will be benefited. Not that you are just directly going to do endoscopic surgery or robot-assisted surgery, take out the disc out so that patient is happy. So that is how we are losing our clinical acumen. We are losing our, gradually our decision making in treating that patient. That should not happen. Though AI is helpful, it should be a corollary to our clinical diagnosis and clinical judgment.
Thank you, sir. It means that the final decision will be humans only, and AI cannot replace the humans.
Correct, I agree.
Thank you.
We are ruling planet. Our species is ruling planet, and I think our brain cannot be definitely replaced by AI. That's for sure.
Sure.
So my next question is to Dr. Ravindra Devkar, sir. Sir, in your field of forensic medicine, there are very crucial moments when you have to do criminal investigations. Like, आपके decisions पे किसी का life निर्भर रहता है. So, I want to know what is the impact of AI in criminal investigation.
So, very apt question, Dr. Deepika. So, good morning all. So, first, I want to thank our organizing president, Dr. Sangeeta Rawat. With her great initiative, we are here and we have such a great platform. We are thankful to our organizing Vice President, Dr. Desai sir, Dr. Patak sir, our organizing secretary, Dr. Roshan Wade, our treasurer, Dr. Charan Lanjewar, and whole organizing team. So, this is only the effect of AI, and considering the forensic impact, everyone knows what security measures and what things we need to do whenever some untoward incidents happen. And as you said, in crime scene investigation, so this everyone knows now technology is so advanced. Till date, considering the evidence, the justice percentage is very negligible, and considering appropriate use of this advanced technology, AI-based algorithm, certainly this justice rate can be increased. But again, this AI algorithm are not appropriate. There is no appropriate data uploading, and hence there may be wrong results. There may be different biases. There are various ethical concerns, legal concerns, as even aptly Neeraj sir told, that in foreign countries there are appropriate laws with data privacy and related concern. So these laws yet to evolve in our country. These things are not made. Again, day by day this AI is advancing. So its implications, its use is not in control. So we need to have appropriate legal framework. There should be data privacy policy, and all these need to be implemented. Here in crime scene investigation, we are just using these AI based things, but certainly its appropriate concerns and considering this towards giving a justice is certainly questionable in today's era. So I always tell that everyone knows that forensic is not just a post-mortem thing. So this post-mortem, so our Vade sir says he is a forensic and post-mortem person, used to cut whole bodies. So this is not the thing. So our doctor thinks that this post-mortem is, forensic means only post-mortem, but post-mortem is only 10% part. And this 90% ante-mortem forensic is yet neglected, and considering this AI era, certainly this field is evolving, and all this evidence-based analysis will be certainly take a great shape, and there is a great opportunities considering the AI.
Yeah, just to add, you know, AI works on the GIGO principle, GIGO, garbage in, garbage out. So if you feed in incorrect data as a human brain, then you know what is coming out. So one must remember that.
Definitely.
Always due to such wrong data uploading, there will be wrong results, and there will be false implications regarding the justice to
So we all
the
have
concern.
to remember that AI just, whatever input you put, it gives you the output. So your input has to be correct, and it is more data dependent. So that's what we take as a point from here. I would like to ask Dr. Neeraj sir, so what do you think in our healthcare setting? Is AI a boon, and why?
Okay, so I consider AI as a boon to our practice, especially talking about neurology, because we have been better off in diagnosing strokes, in reading the lot of amount of EEGs. We do video EEG for 3 days. The amount of time it takes to review one video EEG, it is huge. But then with the AI models in which there are spike detection softwares, so we can detect and go on that particular event and analyze it quickly. So definitely the AI is a boon to the clinical practice, but it is not a replacement. So there is a concept called as human in the loop, HITL concept. So humans should be included in the loop of the decisions for all clinical practice, and it should not be out of loop. So eventually the machine will just give you data, but then humans have to interpret it and really do it in the clinical practice. The second important boon is that it can replace lot of administrative hustles. So if you want to make a patient summary, you can just dictate, and AI would basically summarize the findings, and it can increase your clinical time with the patient, because the administrative or the writing work can very well be handled by the AI softwares. The third is some of the data which we store are not in the actual context of research. For example, in hospitals, the medical insurance related data or the data which is there in the IPD records, if they are all digitalized, the AI can definitely help us to extract the data from those entities which are not research oriented, and definitely it can be used for the research. And I think that if humans are involved as a supervisory role, then AI has much more to do in our clinical practice.
So if we use it rightly, it is definitely a boon for us. Yes, sir. Thank you, sir. Jack, sir, next question is for you. Can you comment on how AI is being used in KEM? Because, we are all working in KEM. So how is it used in surgical field, and how better can we use it?
So I'll take the example of our Department of General Surgery, and I can see my colleagues here. So two distinct major disease pattern which we see coming to our OPD. One is the patient with gallstone disease, and second is patient with hernia. So in fact, what was happening was that in a month we used to get, say, 20 to 30 patients over a period of time. And we used to find it difficult that which patients we need to prioritize for the surgery. We know that there is a pathway of giving a note, and then, you sending me a patient that is my note case, please do it. But then in AI, what has happened is that on predictive parameters, today we have given a thesis to one of the topics where I can know out of these 20 patients, if this patient is not operated, he will come with an early complication. So it has helped us to streamline that waiting list. Preoperatively, today with AI, we can also on the imaging find out whether this patient with gallstone disease will also require something like an MRCP because there's a stone which has slipped down or no. So it helps me a better planning. Intraoperatively, it has helped me to understand that which steps of the operations, if performed, say if I make the operation from step 1 to step 10, it might tell me that in step number 6, 7 and 8, you need to be a little bit different in this patient because the anatomy is different based on the preoperative imaging. And post-operatively, I think the most important game changer would be the recording of the operation notes. So today we have developed a tool where I do a voice recording and my time of typing the notes and that error has gone away. So we do a voice recording, it gets encaptured, and at the same time if I need the data that please give me the record of patients with stones more than this size over last 1 month, immediately it will produce back. So I think research-wise in an institution like ours, each one of us should find out that which are the top 10 procedures which we do in our department, and if we can put in AI into those top 10 and start with the resources, I think it will be a big game changer. So I think we have adopted it in a very big way. Slowly, I think once we get the robot, things will move much faster. So I think in this way, as far as our department is concerned, we have identified those things and we are moving in that direction. Thank you.
So I think this can be done for all the departments.
Absolutely. We should find out the top 5 or the top 10 pattern which we see, and if we can offload that part, I think it will be a great thing for an institution.
So there is a software called as AI Pen, in which like in routine practice we write that patient has come with so and so complaints since 5 months, 6 months. So in that you take the history and just dictate to the AI that such and such 23-year-old male presented with history of headaches in so much duration. It just summarizes in just a bit of second, and you can synchronize between your mobile and it will directly go on your computer, and you can just give a summary in immediate 5 minutes. So I think
this is the best thing that has happened to our residents, because they invest a lot of time in writing notes and documentation, and this would really help them out.
Absolutely. So I think just adding on to that, we are also inculcating the habit of using ChatGPT, and now we have Gemini, which is for Android people. So we should start doing that big time, because if we all practice for small things, what will happen is it will also make us getting better and interested in that. So I would plead each one of you that who are Apple users, start using ChatGPT. If you're an Android user, start using Gemini and see how you can interact with that, what question answers you are getting, and let us start it. So I always use this frame, catch them young. When you catch people young and give that particular technology, then they will inculcate in their clinical practice.
Yeah, I think the students are already using ChatGPT because we do find similarities when we get their protocols.
So when they ask a very tricky question, I usually know that it has come from ChatGPT.
Yeah. But I think it's a good opportunity that even teachers start using it for their betterment, like wherever they can use it.
Absolutely,
Definitely.
absolutely.
Yes. My next question is to Jadhav sir. So with all this use of AI that we have all discussed, do you think we are going to be over-dependent on it in terms of diagnosis and treatment?
Yeah, a very nice question, madam. When I look towards this technology as a teacher in a teaching hospital, and the patient who comes for his treatment or for his well-being, the most important thing is accurate diagnosis, pinpoint diagnosis, because if my diagnosis is wrong, my treatment will be wrong. Now, being a teaching institute, here you have to teach students, and the downward side of every learning program, the teaching curve. So in that teaching curve, we do make mistakes. We have also made mistakes. We have done wrong diagnosis, and then we have repented. So now you have to use this technology in achieving the right diagnosis effortlessly, seamlessly, by using the scans which you have. Now it has been seen that even in the best of the centers worldwide, a thesis which was concluded with the remark that 10% of the fractures which were detected by the AI incorporated scanner systems were missed by the orthopedicians in clinical practice. So to achieve the right diagnosis, we can use these tools in teaching institutes. Secondly, the interaction between a teacher and a student basically. Sometimes it becomes very difficult for a student to learn the process of acute management, and in that acute setting, the teacher's mental frame is not to teach the student. He is in a direct dilemma to treat the patient. So there the interaction of the teacher, student and the patient, because sometimes you might not be directly in the field. So there, using these artificial intelligence tools, these chats, Google Assistants, they will help us in propagating the right diagnosis, and the learning of that student, it will be very, very simpler. Then using this technology, we can develop a system where the patient satisfaction will be the utmost. He will become much more well versed with the technology, a smart patient who will approach the doctor immediately. Then there are tools which are there which will detect abnormalities. They can be worn by the patient like smartwatches, rings, or we have our electrocardiogram monitoring, Holter monitoring, and all these things, they will aid the diagnosis, and when the diagnosis is reached, the treatment part also. Like in rare diseases, there is always a dilemma that if my exposure is not there for that disease, so my mind doesn't know how to proceed. So immediately taking help of this AI, I might reach the treatment options also. Like in our cases, what should be the ideal treatment? A patient with a coronary artery disease, now he comes with blockages in his coronary arteries. Now always surgery is the last preference, but then you can incorporate data, discuss with the patient and give him guidelines. So medico-legally also, it becomes easier for me to make him understand that yes, angioplasty is a better option in this scenario. The worldwide references which are there, they guide that your disease is in stage 3, so you go for a bypass surgery or a hybrid approach, a minimally invasive approach. Then incorporating AI and the surgical things, like sir rightly said that virtual training of the student. Like I can prepare a model of the surgery, like if I have to operate on a tetralogy of fallow, and my student has to learn. So I feed in the data, I create a model of that tetralogy of fallow, that VSD is there, overriding of aorta is like this. The student practices it rather than directly going in the surgical field and landing in catastrophe. He does that surgery, he is virtually examined, and then he is told, you have taken a wrong stitch here, before only. Like in coronary artery bypass surgery, where should I place my graft? So that is done in a virtual lab. So while training also, I will be much more far better placed as a teacher. And using these tools, I can give adequate and appropriate treatment to the patient. Yeah, thank you very much.
Yeah, definitely, sir. So, my next question is to Mohanty, sir. So, as Jadhav sir rightly said that we can use this AI to, sharpen our skills. But do you think our minds will rust if we start using AI and be dependent on it for everything?
Yeah, that's true. That it's not the minds, it's the, your clinical acumen, which is, you touch the patient, you examine the patient, and then you see there is a mass, or you suspect there is a fracture, then only AI will help you to establish the diagnosis. Sir gave the example of say fractures. So for diagnosing fracture, suppose you have to validate the AI, what is known as validation of the data. So you feed the computer, suppose 100 normal X-rays and 100 fracture X-rays, and tell these are the normal X-rays and these are the fracture X-rays. Then only the computer will tell you that this is the fracture X-ray. So what is known as a validation of the data. then suppose sometime the radiologist makes exposure little high or little low. In those cases, again it requires a revalidation of the data if you are changing the exposure of the X-ray. Suppose the patient brings the X-ray from somewhere else, somewhere outside, some private X-ray machine, and brings that X-ray and shows you that. So again, that requires what is known as the external validation of the data. So these are important things in the AI. There is an internal validation or external validation of the data which is required prior to in order to diagnose, and there you lose the clinical acumen. While treating the patients also, there is something, it's not that the medications you give or do the surgery only do. You require some kind of empathy and sympathy towards the patient, which is extremely important for the healing of the patient or healing of the disease itself. So that will, AI lacks that. Now somebody told, I think McCarthy or so, can the machines think? So that is a big question. You as a human being, you think, but the machines cannot think. So that requires the sympathy and empathy which is lacking in AI, and people, if you are more and more dependent on AI, then you will lose this thing, this aspect of the healing, and it becomes more mechanical rather than your human touch to the patient.
Definitely, sir. Human touch has to be there when we do patient services. So,
Deepika, can I make a quick point? Yeah?
Yes, sir.
So the subject expert is here. Your question was very pertinent, that is it rusting our mind? He will agree with me that the human brains today we are using less than 10% of our full capacity. In fact, I feel that AI is awakening those neurons which we have not used. So I don't think it's rusting, it's a wrong thing. In fact, he'll agree with me that it's simulating, and we'll probably come to that level where optimally we are utilizing. Correct, Neeraj? You agree with me?
Yeah, I agree with you, but as a teachers, we definitely need to incorporate, because for students, clinical learning remains the best. So after the clinical learning, they can incorporate AI into their, education. But then first remains as clinical.
definitely, sir. And as Gandhi sir said, that we have to use it in the right way so that we, we ignite our neurons which have been resting for a while.
Yes.
Definitely. So to make this panel discussion a bit more interesting, we'll invite 2 questions from audience also. So till our next question is answered, I request if someone from audience has questions, they can send their question. Yes.
Thank you very much. I am Dr. Yavlekar. Now, the first thing is, let me compliment the organizing committee that such a relevant topic has been chosen. Second, all the experts, though you are called as panelists, I know Uday Jadhav very personally, but still all of you have given a very balanced account of AI. One small thing, initially AI was considered as a monster, unbottled, and it can be proved to be something like a curse. But as we are progressing, we realize it is a good friend. And somebody here remarked, AI is there to survive. But there have been apprehensions and fears whether we are going to survive or not. So it was looked upon as a threat to mankind. And as far as the student community is concerned, now the responsibility of the teachers is increased, because in AI is a parallel teacher, and maybe in some aspects he is a superior teacher. So maybe teachers will have to be put on alert. That is something very important. And last, of course, somewhere it is criticized that AI amounts to outsourcing your cerebration. So we should not allow that to happen. Thank you very much, both of you.
Thank you, sir. The next question is Dr.
Yeah, can I ask the question, please, to the panelist? So, as AI is whatever machine has been created by the human mind, so the major disadvantage, according to my opinion, would be what is not given, AI is not going to give that answer. So there are a lot of things in the health system and the medical fraternity that as we are a treating physician or professionals, we don't know what is going to happen with them, right? Even the diagnosis, like the COVID had come, so nobody was naming. So there are the things which are the disadvantage, most important of the AI. Another thing in over-diagnosis of something with the AI. Over-diagnosis, now a lot of people, corporate worlds are using the smart watches. And everybody with a small ectopic in one of the lead or ECG, they will call you, they will come to the clinic and say, "Sab mere ko ye BP bhi aaya hai." So that increases the stress of not only the doctor but also of the patient, right? So that has to be balanced well. third thing I want to talk about, we generally, whenever new modality comes in the any medical fraternity, we try to conclude very early. Okay, I feel that we are too early to conclude what we need to do with the AI, and it with the over the period, maybe years together, it will tell us, yes, this is good for this and this is bad for that. Okay, so I think our opinion should be balanced depending on the patient care and the different fraternity. Thank you very much.
Thanks,
Very
Charan.
true, sir. Thank you, Dr. Charan. The next question is to Dr. Devkar. Is there any possibility that justice be denied to the needy with the use of artificial intelligence?
So very apt question, Dr. Urvashi. So everyone is talking about these forensic aspects, ethical issues, and its legal implication. So yes, justice will be certainly denied to the needy because of use of this AI. So as even in my answer of first question, I told that this all AI based answer is based on whatever data feed to the internet. So whatever data uploaded, is it correct? So you are believing on whatever result given by computers, whatever results related to things asked as AI based, as Uday sir told that yes, seniors can guide all juniors with their clinical acumen. Using their clinical acumen, they can upload different algorithms and all these things. But there are negative impacts of all this. So later on, one day will come where seniors will just give the guidelines, just take a visual round, and all juniors will going to do the surgeries. The healthcare services will be delivered by the juniors who don't have enough experience. They are just following the algorithm. So considering this Consumer Protection Act, the responsibility, you know, the doctrine of vicarious responsibility, respondent superior. So again, if there are some mistakes, there is a complaint related with negligence, to whom you will allocate the responsibility? You can say that I have prepared the algorithm, I have uploaded the policy, so my junior, my resident done whatever operations, whatever services delivered, so I am not responsible for this. So there may be some mistakes. As you are uploading the data, someone else again uploading the data. So AI will give the results which is uploaded with higher numbers. So again, that data may not be correct. Another implication is, if you are very much bound to AI based system, later on, as like the various units of hotels, so like Taj hotels, so there will be various units of Dr. Uday clinics. So he will put up an algorithm, he will ask certain policies AI based, and there will be certain clones of Dr. Uday who are giving the treatment management to patient. So certainly again there will be issue related with justice. If some untoward event happen, if the things go wrong, then who is responsible? So we need to have appropriate policy, we need to have appropriate data protection policy. Whatever things uploaded should be checked and should have authentic information. Another most important thing I want to tell, that we are towards advanced technology. We are going towards genomic studies, personalized drug, precision drug. So where we are narrowing the field and giving subject-based, patient-based, personalized treatment. And here, on the other hand, you are setting a general AI algorithm for treatment of all patients. So this AI-based treatment goes on generalized thing, and here our advanced technology is going towards giving personalized management. And as aptly point raised by our Mohanty sir regarding the empathy. So this empathy will certainly vanish off by the time. So we need to have appropriate empathetic approach. So human touch is very important. Whatever algorithm, whatever things should be supervised by appropriate clinician, and this is need of time, and there should be appropriate responsibility allocation, and that will certainly give justice to the patient, and this will have a great forensic implications. So as I said, this 90% part of forensic medicine, antemortem forensic, so it's have a great impact in relation with this new era of AI.
Definitely, sir.
So,
Yeah, we have to.
is there any conclusion out of debate that we have to go with AI, or we can still believe on our original clinical skills?
So,
or we are completely sold out to technology?
So considering me, there should have a human touch, there should be appropriate supervision. Certainly AI can aid us, but it cannot replace us.
So in post-mortem, it doesn't make any difference. But ante-mortem, where Dr. Mohanty, Dr. Jignesh Gandhi, that are cardiac surgeon, Dr. Jadhav, so all these guys, is a technology is going to be a boon, which is going to replace your surgical skills, which you acquired over years.
Can I take that?
Are you sure that robo, which is there in your theater, is going to take over Dr. Mohanty or Dr. Mohan Desai and perform the surgery? Is CABG will be replaced by a robotic CABG? Answer should be very quick and fast.
Roshan, last week, there is a Rajasthan Orthopedic Association State Conference.
So do you believe in AI?
I am telling you, one of the famous South Indian surgeon was performing a live surgery with a robot. He has done hundreds of live surgeries, but in that particular surgery, he saw when he was taking the anterior cut, he was just right cutting through the middle of the femur. He tried to do it repeatedly, but it happened same thing. He has to abandon the surgery and go for a manual surgery.
Jignesh, you are operating.
Not going to replace the surgery.
Roshan, I'll respond to it very quickly. We have got teachers here. 3 skills when we use for learning: cognitive skills, affection skills, and psychomotor skills. My teachers here, Nima, Rega, Madam, and everyone. Till the time the robot doesn't become autonomous in my psychomotor skills, I am happy because it is helping me. Cognitive skills today, it has helped me a lot. Affection skills, it has affected me a lot. But as far as the psychomotor skills are concerned, robot today has helped me to perform better. But the day it will become autonomous, I agree with you, Roshan, it will be dangerous for everyone.
Do you go in theater or you sit in your changing room?
We will be in the theater because it is used as an aid. But the day the robot will become autonomous, it will be dangerous. And that is where what your answer is will be affected. Let's go to Dr. Kantharia. Yeah, he's got a comment.
Can we have Mike there, please?
Volunteers?
Yeah, I want to make a comment that however much we may debate now, one thing is for certain, that AI is here to stay in medicine. What is important is we have to use it judiciously, taking into consideration ethical issues, and what Jignesh said is very important, that let it not become autonomous. You should be controlling it, not the AI.
Absolutely. Well
Absolutely, sir. I think we all, as doctors, we have to, we have to agree to it that it is there to help us. Let's take its help wherever possible. And as Sir rightly said, we cannot make it autonomous. Yeah. Yes, ma'am.
Excellent panel. One simple question. How many of you used ChatGPT before coming on the dais? And how many of you said exactly what your ChatGPT told you? Have you used only ChatGPT, or you used your experience and your personal whatever information you have? Because ChatGPT has many uses, right?
So I'll start with that answer. My disclaimer is I don't use ChatGPT because I have already founded a company called Arista Search, which I have taken a course from Stanford and I've already got certified in that. So my disclaimer is I have not used it, but yes, I do use ChatGPT for my other decision makings when it is required, but not for this panel discussion for sure. That's my disclaimer.
Yeah. And And Dr. Gandhi, I think this sort of teaching should continue in KEM also.
Absolutely.
Whatever you learn from Stanford, you should be teaching all the
Yeah.
faculty
So,
of
yeah,
KEM.
absolutely.
That's your
In fact, I'm
request.
very happy that Madam has taken up this topic, and we can also have a department where we can have a team, which can be an artificial intelligence team like the rest of the world, and we can all have experts here because all these people are more learned. I can see that, and we can do that.
Definitely take help of that.
Prabhu has a
Because
quick
of,
comment.
So
time
whatever
cons-
question raised by Dr. Deepa madam, so answer lies in it. Madam said that have you used ChatGPT? So here we are presenting, not ChatGPT is presenting. We are here, and hence human touch is very important.
Deepika,
You
let me-
need to use
let me-
whatever your
Yes, Prabhu.
resources appropriately.
Let me quote, Jeffrey Hunter. Couple of months back, you must have read Times of India. Jeffrey Hunter is considered as the godfather of AI. And he was working for Google and as a Nobel Prize winner for physics in 2024. What he has told, there is an existential crisis of human brain now in future. He left Google and he committed that whatever I have done a mistake. See, right now, most of the money in US is being, invested for the development of AI, 99% of money, and only 1% money is being utilized for adverse effects or what are the side effects of AI. At least there should be 50% utilization of the money for the research, for the development, as well as to look towards what is the side effects of AI. That should be the conclusion. AI is here to stay, but we must use it with our human brain. When you will see that AI is crossing or overtaking the human brain, that is the end of this human era. Thank you.
Definitely, sir. We would agree.
Can I just add one more thing?
Yeah, so we'll make this as a last question because we are already running short
I
of
just
time.
want to ask the panelists, AI gives you an algorithm based on what is their available data. So it will stop innovations. Like whatever innovations, surgical or medical innovations, what you are thinking will never come in your AI because it has never been proved. So all your research, whatever you are planning or your plans, what you want to do in a surgery will be challenged by the person if the AI is being used extensively. So in medical fraternity, whenever the innovation part is going to be there, AI will always challenge your technique. So I don't think AI is, as of now, is so mature for us to implement it wholly in our practice. Because
Yes,
innovations will be affected and not come up.
Definitely, sir. So,
Prabhu, probably I'll just respond to that quickly. I think you have not used ChatGPT.
have
You
used
put in ChatGPT and then it'll give you an option, generate a better response. The
You
moment you
can
click on that,
generate-
and once you write generate a better response, which is highly intellectual, see the answer,
No,
you will
the
need
answers-
ChatGPT even to interpret
no,
that.
In that, if you put give me reference, it will give you references. It is not its intelligence. It is whatever is available to you, it will give you a better answer out of it.
Deepika, can I
So-
just make a last comment about,
Yes, definitely,
So
sir.
just for the knowledge of everyone, there's a company called M42, you can probably Google it later. The first in the world, in the UAE, every patient's data in Abu Dhabi is been taken that it is there on the data, you have to give it to the company. And I'm telling you, this will be the first health Google map of the world. So what they're trying to put in is like we want to go from destination A to B, I will decide that if I want a treatment like CABG, it will give an option. But the moment I got off the option, it will give me a red bar saying that you have taken a wrong turn like the Google map. So it's very interesting to know that we will be all using an app in the future that I have got this disease, how do I go from here to there, meet him or directly go and meet him. So that is the way it's going to be. So M42 it is there. Please look into it. It's very interesting to know how the world is moving ahead. Thank
yes,
you.
definitely, sir. And I think this is a never-ending topic that we all, are interested. But if we go on, it will take a day. So we need to conclude here. So I would like to have some concluding statements. Just one statement from each of you. One statement about AI.
Yeah. So as rightly said, we have to use AI judiciously, keep the human touch intact, and the learning and dissipating of medical knowledge. It has to go like from a Guru Shishya Parampara, so that has to be there maintained.
Rightly said, sir. Just one comment, sir. Yeah.
So artificial intelligence is here to stay. Believe in the concept. Perceive the ideas which you want and you will receive what you will get out of it.
Definitely.
I think at present we use AI as a research tool, and use it as a clinical assistant, not as sole decision making.
Very true,
Thank
sir.
We are just following Western countries blindly. We must see what is our problem in India, and we should use AI judiciously for our problem, local problem, for our own patient, for our institute. Judicious.
Yeah. Ma'am, one comment on the ethical aspect, if you like.
Again, what Prabhu asked, you have to upload your own data so that you can form your own algorithm. So make sure that the data is representative of your own subset.
Madam, the problem with AI, it will see your data, what you have said versus 10 other people. So innovation will never come in the algorithm till the 10 other people are there in your against you. So it may not come as a treatment option, though it may be a better option. So all your innovations will be questioned by AI. So tomorrow in the court of law, if the judge starts using AI, all your algorithms which you use clinical experience will be questioned because it is not there in the AI.
Basically,
so I
you have
think
to
it
see
should,
that the data
so
is
ethically
representative.
it should not come in the practice, because it is going to happen that tomorrow in the consumer court, the judge will look at the AI, answer from a chat GPT or chat Gemini, and say, no, this is the algorithm which you should have followed.
Yeah. So I think we'll have some more discussion in, while we are having lunch.
It is judicious use. You have to use it judiciously. That
Definitely, yes.
Yes. So at the end, I am giving a conclusive rule of 3 S. So as Sir said, the youth should be judicious. So first S is our healthcare services. So we need to deliver our healthcare services appropriately. And this second and third is safety and security. Yes, we have ethical concerns related with patient care, and we need to have appropriate safety measures, security measures. So there should be stringent legal policies, legal framework, appropriate policy, government policy should be there, and then only then this AI based applications can be considered in medical profession, and always this AI based application should be supervised. That is, human touch is very important, and our clinicians should use it appropriately. So personal touch is very important.
Definitely,
so
sir.
AI cannot replace human.
So as
Thank
of
you.
today, we conclude that it is not there to replace us, but we have to use it judiciously and in the best possible way. So I thank all the panelists, you to give your valuable time, and I think it was one of the very interesting discussions, and we will have more during lunch. I think a lot of people have a lot of questions. So I hand over to Urvashi now.
I request Dr. Deepika now to felicitate the panelists. Dr. Deepika, please felicitate Dr. Uday Jadhav. I request Deepika ma'am to felicitate Dr. Jignesh Gandhi. I request Deepika ma'am again to felicitate Dr. Neeraj Jain. I request Deepika ma'am to felicitate Dr. Amla Kudalkar. I request Dr. Deepika to felicitate Dr. Shubhranshu Mohanty. I request Dr. Roshan sir to felicitate Dr. Ravindra Devkar sir. I request Roshan sir again to felicitate our moderator Dr. Deepika. invite Dr. Siddhi ma'am and Dr. Shilpa Shri on stage. Roshan sir, please, can you stay for a moment? I request Roshan sir to felicitate our previous moderators, Dr. Siddhi ma'am and Dr. Shilpa Shri ma'am. Thank you, Roshan sir. Now I would request Dr. Sikandar Banu to introduce the next panel of discussion.
I think in interest of time, by the time people gather here for group photo, I'll request all the panelists to be on dais because we don't want to spend any time. We are already late by 15-20 minutes, so we have to pick up that time. So we'll miss the informal introduction. I think all of us know each other. We know more than what individual is, what are his capabilities, what is his qualities. So I feel a formal introduction, we can miss it. And we want to make it more and more interactive session rather than a monologue or didactic lecture so that more people can interact, like what last session of your AI has happened. Because we want more faculty to participate in discussion so that a conclusion amongst the students can reach to a final conclusion.
So after enlightening discussion on AI in clinical practice, we will have the next panel discussion, that is training in India versus training abroad. So we know we stand at the intersection of critical question that many medical students and professionals ponder. Where should one pursue medical training, India or abroad? Both paths offer unique experiences, challenges and opportunities. Let us explore key aspects of the medical education in India and compare it with the prospects of training abroad. So without further ado, let us embark on this enlightening journey. Please join me in extending warm welcome to our moderators, that is Dr. Kavita Joshi ma'am and Dr. Praveen Shinde sir.
Good afternoon all. As correctly, Madam has skipped the introduction. So I am Dr. Praveen Shinde, and this session was supposed to end by 12:15, but it has started at 12:20. So I'll be really very quick, and it is my privilege to welcome all of you for this panel discussion, which is on a very, very important topic of medical training in India versus abroad. You know, in the era where the healthcare systems are rapidly evolving and the global recognition is very, very crucial, I think, you know, the training of medical professionals has become more and more important, and this is why this topic today. So we have about 6 panelists today, and Dr. Kavita will introduce them.
Good afternoon, I am Dr. Kavita Joshi. I would like to welcome Dr. Shenvi Madam, who is the HOD of Physiology, and our areas of interest are exercise physiology. I also welcome Dr. Bhushan Kumar Thakur. He is a professor of surgery in our institute, and his areas of interest are endoscopy and laparoscopy. I welcome Dr. Roshan Wade, Associate Professor, Department of Orthopedics. His areas of interest are arthroscopy, sports medicine, and I welcome all of our eminent speakers have numerous publications to their name. I welcome you.
I would also like to welcome Dr. Hetal Marfadia, Head of the Department ENT. I would like to welcome Dr. Chetan Kandaria, Head of the Department GI Surgery. And I would like to welcome Dr. Charan Lanjivar, who is a Unit Head and Professor in Cardiology.
Hello. We should start, I think.
Yeah.
Your time starts now.
Hello. Is this on? I don't know.
Yes, it's on.
Yes,
We can
yes.
hear
So,
you.
without wasting any time, the first question to Dr. Shenvi Madam, that how do the curricula and the teaching methodology in Indian medical institutes compare with those abroad?
With new curriculum, CBME curriculum, I think training in India and abroad has almost become same. Only in research opportunities, our research settings we don't have and infrastructure is not there. And because of this new curriculum, we experience that your student and teacher's ratio is not appropriate, which is there, here it is not. And therefore, teachers don't get time, faculties for research. Even students don't get time because they are fully occupied. So my thing is that training as such in UG and as well as PG, it is same in India. It's as the Western countries.
Dr. Charan, would you like to comment? Are there any difference in the methodology
Mic जवळ घ्या.
in India versus abroad? Is there any difference?
First of all, let me thank the organizing committee for giving us a chance to talk here, and one of the best program I think in last whatever years I am here. This is for the first time such kind of panel discussion is occurring among the interdisciplinary departments. So that's, I think we should give a big applause for this to everyone, to the madam and all the organizing committee here. So yes, absolutely there is a difference. What I feel is curriculum in abroad is basically not only just skill based, it is always academic. It has a lot of options of pursuing your future career depending on UG, PG, whatever the super specialty is. Our Indian curriculum is not skill based, at least for the UGs and the PGs, that much what we have. Second is education wise, we have a different bonds for different things, like UG 1 or 2 year bond, PG you have different year bond, super specialty different. This bond system is not existed in any of the curriculum outside India. That is third thing. Important, one more difference in what best difference is, I will call a research. It is must to produce the papers, number of papers, in a particular time. Suppose you are 6 months in any UG, after 1 year, 1 paper, 2 paper, 3 paper, like a 6 paper, okay, in a whole 3 year duration. This, though it is on paper with us in a super specialty, as most of the teacher will agree here, that we have that, but nobody is strict about this, okay. Even our department is not strict. When we give the signing on the, when they come for the exam form, we allow them. But ideally, there has to be strictness maintained such that some quality work will be done in a different departments, which will help us to produce a quality work in a research and publication. One difference, I will again talk about research. If you say the funds, what we funds in our research we have in India, they are very minuscule. If you compare the abroad fund, if you label the US fund, US funds about $48 billion per annum as far as research is concerned. In India, ICMR funds not 1 billion also. So depending on that, whatever the expenditure, we are going to suffer.
अरे
okay?
आगे question पूछने दो ना.
So
This is what happened if you are trained abroad. You don't allow others to ask questions.
Kantarya sir, I would like to ask you the question. Hello. Indian state-run institute often provides significant clinical exposure due to high patient load. Does this exposure compare with the abroad? Like, do we have a better clinical exposure for PGs and UGs over here in India or versus abroad? What do you think about that?
So yes, we definitely have much more clinical exposure both at UG and PG level as far as the workload is concerned and the patients are concerned. Having said so, but does it work to our advantage of our residents? Because at UG level what happens is that though there is enough of clinical patients and clinical cases available, most of our second year students, if you see right from second year, they have started preparing for the NEET. And similarly for the PG level, because there are number of residents are less, though you get lots of cases,
Ideally, they should be clinically analyzing themselves, these cases, and reflecting upon it and trying to reach it. But their main motive is to complete that day's particular ward work so that the patient is ready. So though there is an advantage in terms of enough clinical material, it does not translate to clinical advantage of our UGs and PGs. Having only few of them may go out of their way to do so. But in general, it doesn't work to an advantage, though we have more patients.
I request Dr. Thakur to comment on Indian scenario, please.
Thanks, Staff Research Society. And I just want to comment on not on Indian training and not on abroad training. I'm talking about KM training. What is the ground level reality? Mainly, who is responsible for this ground level reality? Whether it's a government curriculum, who is keeping busy all the time students in all entrance exam. After UG, they want to give PG exam, then super specialty exam, and they are continue busy for this competitive exam, and everybody wants to do a scoring. But as compared to this system, then second part responsible is should myself or our staff, means our teaching profession is responsible for their assessment or for their casual attitude. Nowadays we have to pass everyone. There is a, means this is a taken for granted from the student also. They are, because of this competitive exam, how they are taking interest in clinical aspect as well as their hands-on training. There are so many patients. We are very lucky we are in a prime institute, tertiary care of institute KM as compared to rural area. But what is the response from our student? Whether they are having their willpower to come and learn, they want to do hands-on training. This is a main
Dr.
problem.
Bhushan, you want to say that the increased clinical workload available, is it advantages or not for our setup? That you tell us.
Definitely. But sir, my question is, what is the implementation? How much you
that
are
we will
going
come
to assist?
I think we are here to answer and not to ask questions. We are here to ask questions. So moving on, I would like to ask Dr. Hetal Marfatia that, how does the duration of the medical training in India differs from the countries like US and UK, and what are the implications for graduates' readiness to practice and pursue their specialization?
The training abroad has got limited hours of work. So they have enough time for recapitulating what they've done in a day. They have enough time for research. They have enough time for publication. Here, for writing publication, the boss will write and the student's name are added. The students are not even a part of it, just because the publications are required. So what is the meaning of this kind of publication? There's no meaning. But actually speaking, if they have just no time to sleep and eat, where is the time for research? So that is where we lag behind. Good clinical exposure is available, but how many of them are using it? As it is said that they have to prepare only for competitive exams. So strategically the system in India has been destroyed. At least clinical expertise has gone.
So if I have
systematically destroyed. Because at least it was not like this. You put a, NMC will put the rules, 2 publication has to be there. Is there a time given to them? There are some hospitals which will do no work. So we will get reference from Sayan Nair also here.
You mean to say the CBME has right mind, but
just
it is
by
not
blindly
being
copying it, it is it cannot be implemented, because you have to see the workload, you have to see the student-teachers ratio.
So if I have to answer your question to the point, the US system, the entry level is at a graduate level.
Correct.
Whereas in R, it is at undergraduate level.
Yeah.
Besides, ours is very structured. UG, NEET, means 12th standard, NEET, MBBS 5.5 years course, a break, maybe 1 or 2 years, or directly so specialty, again a break, or maybe directly this. Whereas if you see in US, you graduate in whatever field you want. Maybe you may be doing an engineering field or literature. Then you appear for an entrance exam. Based upon your essay, on your entrance marks, your recommendations, then you are selected for a medical education. Then first year is preclinical, and their clinical rounds starts from first year onwards. So the exposure to the patients is very early. Then at the end of 2 years, they have what USMLE Part 1. At end of 3 years, you have USMLE Part 2, and then you go for clinical rotations of your choice. You can select any hospital. After that, you get an MD degree, following which there is a compulsory residential rotation. You give your exit exam, and depending upon what specialty you get your exit exam, you will get a specialty degree in that particular field. So the students are more matured, they are more thorough, they are very sure of what they want, and hence they are more ready to pursue their profession. Whereas in our case, you see, there is a consensus in 2023 publications. It was seen that of these 612 medical colleges in India, almost around 91,200 residents, they migrated abroad for another course. So this tells you that how they are unready, because in our system, the medical education is very easy to pursue as compared to abroad. So our students are not ready at the end of their course to pursue, and they require to do senior residency as a must, which is now being followed.
Yes, Dr. Wadi, you have any comment to make on that?
I think these guys are trained abroad, right?
Yes.
You are representing training abroad, and we are supposed to represent training in India. I think, how many of you are trained in India? Please raise the hand. Anybody is trained abroad?
All of us are trained
No.
in India.
Anybody is trained abroad? Abroad. Yes, there is 1 hand, 2 hand, 3 hand, 4 hand. Who? Akash? तू तो साला यहीं का है? थोड़े दिन के लिए. Okay.
All of them have been trained abroad.
Yes.
Whoever is here is trained in India. They have gone for a short stint abroad.
Okay. So let me break the myth. As Dr. Hetal has rightly pointed out, the systemic destruction of the medical education system, which has happened post-90. तो लाओ रे जो वीडियो लाओ जरा, लाओ रे तो वीडियो. Make in India.
कुठला व्हिडिओ लावतो तो?
बघा तर.
पॉलिटिकल नाही ना?
So this was 90s. 90s. We made best of the best doctors before 90s. What has changed post 90s? Something had drastically changed. The corporate structure, the politicians, the bureaucrats, they tried to destroy the medical education with the help of NMC, MCI, or CBME, everywhere. So I feel a systemic destruction of a very good system. Is it that we never made a good doctor before 90s?
We always made very good doctors.
Yes. So what had changed was the systemic destruction of the system. And about the skills, how many of you feel that number of patients in America are more than India? Anyone? We are 1.6 billion, today number 1 country in the world. So if I have to consider number of shoulders, I have 3.2 billion shoulders to offer surgery.
Dr. Roshan, we are not
So
talking
clinical
about
volume,
statistics.
we are number 1. I'll come back one by one.
Abroad help or not?
Yeah, I will tell you, I am completely made in India. I am made in KEM. I am made in Parel. I was nothing before I came to KEM.
But Roshan, that discussion can't be here, you know.
No.
We are
People,
talking on a
I know
topic.
people who came back from training in
We are
India and
talking
again
on a
trained
topic
here.
whether
So many of them,
will
I
get
think,
more benefit
many
from
of
doctor
them-
education
I think we need to
or
stop
from
here.
a local education.
Dr.
This
Lanjewar,
is
we
your
need to-
topic is going somewhere else.
We are diverting from the topic, I guess.
Dr.
Dr. Wade, I want to congratulate you. Really, a doctor who's trained in India could have thought of that song, Made in India. So I really want to congratulate you. Moving on.
Next question to Dr. Roshan himself. Considering the tuition and living expenses, do you think medical education in India is cheaper as compared to the medical education in US or UK? What are your thoughts about that?
So, we are all trained in KEM, JJ or some government institute, so we don't think about the cost. But when you compare to the private medical college, obviously it's very expensive in India as compared to the Chinese and Russian countries where the MBBS is very cheap. But those kind of expertise is less than what we train here. Obviously, we can't compare the MBBS student from KEM or JJ or Sion equal to the who is MBBS from Russia or China or Indonesia. So their volume, their way of training is completely different. I have come across 2-3 such guys. They are not at par with our students.
No, no, also they have to get adjusted to the custom there, the religion there, the language there, the and the clinical exposure is
Living
not as
expenses
good.
also much more
So
over there
actually-
as compared to us.
You may save it on the tuition fees, but then your gain is less. What you spend on the travel is more, and there are a lot of students who come back because they are homesick. You have to really get accustomed to the new culture.
But I think when you speak of comparison, it is comparison with US, UK and India. So if you consider US, UK as compared to India, they are definitely much more expensive. On an average, it is 30 lakhs per year compared to 2 to 3 lakhs or even 5 or 10 lakhs rupees per year in India in private medical colleges. Besides this, our government gives lot of concessions and aids to various social strata of people of different social strata. So your education is definitely much cheaper as compared to US and UK.
But also the payment is higher during residency, so they just make it.
Yeah, we'll come to that. My next question is to Dr. Thakur about are the scholarship opportunity and the financial aid more accessible in Indian institute or the international ones? And how do they influence student decision to pursue the medical training abroad?
Scholarship opportunities and aid are available in both India as well as abroad, but their accessibility and types of aids are vary. First of all, I just want to give a statistics. As per the Ministry of External Affairs, they quote more than 7.5 lakh students are going abroad every year for their education, and most of them for medical education. Second, from ICCR, that is Indian Council of Cultural Relations, they state there are more than 3,000 scholarship in India for different education purpose every year. And as far as I concern, medical aid for medical student is vary from 3.5 lakhs to 16 lakhs, depends upon their type of aid and scholarship. We have, we talk about the Indian institution later on, foreign institution. First of all, Indian institution, Government of India offers the most of the talented student medical scholarship. Most of them is a national merit cum means scholarship, and second is a central sector scheme scholarship. Second is most of the topper institute in India like AIMS, PGI, they are also having their personal scholarship for their topper student and also for needy student. Those are financially weak. Third is a private organization like Tata sponsorship is there in India, then Reliance sponsorship is also there in India. And international is also having as per their merit cum base, then need cum base. Third one is there also private organizations like
even educational loans are available.
Sorry?
Education loans.
Yes, yes, according to some aid, there is a medical loan is also there for poor students.
But I think that is not a reason people go to US. People go for a better future, better opportunities, better future and other things.
Quality of life.
I think one comment from me. Pay is definitely more in the US, whether it is a residency, whether it is an internship, whether it is a super specialty or any staff. Okay, there is no comparison of the pay. We get 1/10 or 1/20 of the payment. I don't think that needs any discussion on this. Most important discussion what my partner has told you, Dr. Bhushan, that we get a scholarship from India. How many people get scholarship? Can you, in the audience, the same question I will like to ask, whether how many people out of these 100 people got a scholarship? Hardly 1 or 2 people, okay? 1, 2, right? So that's how the statistics is. When you go to abroad in a Western country, there are about 50% people get scholarship, okay? And they are easily approval, and once during the residency, most of them can pay back that is one of the advantage. I'm just talking about the advantage. Second thing, if you see the QS university rank, okay, there is a study, the statistics is QS university rank out of whatever the university over the world is, top 10 are the US universities, like John Hopkins, Mayo Clinic and all. Out of the, how much are the Indian? Indian has 200, that is only the AIMS University, Delhi.
It's 151.
So on that account, you can really tell whether a student, aspiring student, either UG or a PG or super specialist wants to go. Naturally, one more question to the audience. If given a chance, how many of you would like to go to abroad for education? 90 to 100%, right? So everybody has right to live your dream, right? That's everybody's dream. One important thing about Indian, what Dr. Roshan has shown the video to us, and we carried away with the video. We do not want to, what has been put into the video, whether it is analyzed well, what the wrong data is put. So that's the problem with our Indian doctors. So one has to see what's there in the video, approve it, and then go ahead. Thank you.
If I were to tell you the reasons for people going abroad, one is better working opportunity, better salary.
Yeah, that's the real reason. That's the real reason.
Good
Better opportunity, better quality of life.
Personal life, balance, then good working environment. So these are all the reasons why
the training is good. Working environment.
Working environment.
See, that's a different story.
Yeah, we are going to come to the next question, which is about the work-life balance.
We have a questions from floor. Yes.
Praveen, let me correct Charan. You are talking about the cost of medical education. You check what is the cost of medical education of a student in any of the universities which are supported by government there, and what is the cost of education of MBBS which is charged in Mumbai. Let us take the premier institute like KM or AIMS. Our student, how much pay? They must be paying 1/10. If you are going to compare the pay which is given to a resident over there and convert it into Indian rupees, it will be different. Don't convert it.
Dr. Ram, I was talking about the payment what you get, right? I was not talking about the.
You talked about the internship and the residency.
Yes.
Ram, he has come back from Canada, so that itself is a proof that the training is better in India.
I will answer this one more question, okay, what he has put it. Suppose given a chance to all of the audience to stay back in US or Canada, okay, if you are getting a good...
Stay back. Remember the word stay back, not trained.
Okay, how many, after the training, this is after the training, okay?
Training.
No one gets that opportunity.
Who will come back and who will not?
Stay, I'll also go for stay. Training, no.
Hello.
Training, India.
Dr. Roshan, I would like to ask the next question to Dr. Charan. How is the work-life balance? I think you already touched upon it and Madam also touched upon it already. How is the work-life balance between while getting trained for the resident doctors or our students in India as compared to other countries? Also, what are the challenges for eligibility and preparation and recognition for these qualifying exams that Indian students face?
I think second part we have already covered. Dr. Sir has already told about MLE and what preparation we need to do. As in first paragraph is very important, that is work-life balance. If you compare in India versus the Western population, work balance is very much you are taking care in Western countries. What are the following reasons are there? In India, compare the UG student, PG student, again I will go with the sequence, and the super specialty student. There are no designated hours to our PG student. What hours he is to work in the, maybe on the rounds, maybe at the on-call. This system, while in the Western world, there are designated and decided hours. There are no designated off. There are weekend off for the students comparing on the rotation outside in the Western population. That is one advantage. Third is your particularly different hours in a week for a research. You are 5 days you are working, work whatever you are given. 1 day out of that is particularly for research. That's how the difference is research in that community. Sixth difference what I want to say is, anyway, whenever you want to do any work or life balance, you want to take care of your family. That is also important at the same time. You are earning enough. That's why you will be able to take your family life. Third is the time. Okay, in India, how many of us who are practicing outside after our BMC time here? Most of them who are allowed practice are going out, but still on Saturdays and on the whatever days, weekends, we are practicing. We don't go home at 4 o'clock saying that aaj mera practice. But whatever in the outside Western world, they are giving proper weekends off, they are taking care of families. That's how the balance is maintained there. So these are few things which I want to add.
Also, I want to add one thing, that abroad, teachers are only not signing the students' CR sheet.
Yes.
The students also give marks to the teachers.
Two-way
So
assessment,
teachers
yeah.
cannot do bullying
Yes.
and just cannot do what they feel like doing.
Yeah.
Madam, idhar to
And there is no reservation.
See, Dr. Wade called himself very local, Parel, KEM. I beg to differ because I've been working with them for more than 10 years. The whole world, the surgeons of the whole world have come and operated in ROCOT and in spine OT. If you want, the whole world comes and operate in your operation theatres. Are we not learning from them? Does the learning process stop with scholarship and that one-year fellowship? No. The learning process continues. I would say, he will say, I am teaching them. Okay, it's learning and teaching. But we can't say we are not learning from the Western world. We are continuously learning from them. And their research is so robust that we learn from them finally, and we are always quoting them. If I give a talk and I say from what Hospital of Special Surgeries, Orthopedics, it has more meaning than some other hospital. So, Roshan, you are learning from the whole world.
I agree with you, madam. Very nice quote by the madam.
I'll answer that very quickly.
Akash, yeah.
Why we call these Goras? Because you know, when Goras speak, people listen. If a Kala speaks, people don't listen.
No,
that
no,
is
it
the
is
usual
not so.
trend.
It is no longer so.
Fact.
I think let's not
that is,
go
that
on
is
that.
the reason. That is the reason. If you see,
I
go to
totally disagree to
all
it.
international meeting.
This is not about, you are not, you
I
should not talk
totally
about the
disagree
skin
to
color.
whatever you say.
I think let us not go into the racial comments. We have a
So-
question from Dr. Akash Shukla. I think we should give time to him.
Yeah, so two quick points. One is what Dr. Hetal just now said, that the students have the power to rate their teachers and the university take cognizance of those ratings, and accordingly it is the next student is allocated or declined to be allocated to that person. So I think that is extremely important, and something of that sort has to be brought in. The second point is what you learn abroad. One additional point which has not been discussed is the value of a common man's life and quality of support of life. I think that perspective is really missing here. So if you are a commoner, by and large, you get brushed aside in our, because of the simple numbers that we are dealing with. So I think that is something which is to be learned when you train abroad. Thank you.
Thank you, Dr. Shukla.
Can I have one small
Yeah,
comment?
please.
So we are debating for the heck of debating for between training in India and training abroad. But now we have Vasudhaivam Kutumbakam, and it's a government's initiative to have a right for learning and knowledge and for all. So it is a G20. We are giving lectures, and these lectures are online, free to all G20 countries. So you take the message, and same way, so there should not be any division. It's right to knowledge and training for all. So it should be, there should not be any demarcation.
No, but sir, do you believe in training abroad? Sir, Dr. Mohan Desai, sir, do you believe in training abroad? My question to you, being a senior doctor, being a professor who is there in the department since 1992. Just a minute, I'm asking Dr. Mohan Desai, do you believe in training abroad?
I would not be, I wouldn't like to differentiate between these two. Training and knowledge is right of all the students, whether it comes from any source.
So you can't be on two boats. Will you be interested in training abroad?
I don't want to differentiate.
Okay.
I have a right
So it's a
to
diplomatic
learn.
answer. He don't want to.
I want to I have a right to learn from whichever source I want to learn, and I should get that knowledge.
We have to take a side because we are debating.
No, that's not like
If
that.
my course is not met here, then I go abroad. But now it is, the situation is that we have a talent here in India. So whatever we used to take this from abroad, it is available in our own country.
So let me ask Dr. Roshan, if you are given an opportunity to spend 2 weeks with the best shoulder surgeon, would you want
So
want
that's
to go?
not called training. That's the observership.
No, that is irrespective.
It's for
Observership
fun.
is a
It's
part
for
of-
joy.
It's a part of the training.
Come on, you cannot
It's one
just
of the
label it
10
like that.
methods
So
of standard
training,
methods of
training is a structured program.
Roshan, you are
fellowship,
absolutely biased person.
Fellowship.
That's not
That
the
is-
way it is.
That is why I have been invited
Your
here.
comment are already biased.
That is why I have been
That's
invited.
not fair thing.
A
In
biased
debate, it
person
has to
can
be a fair
debate.
deal with each and everyone.
A biased person can
No.
debate best.
As per the curriculum.
Unbiased person
And you
cannot
have taken
debate
the
best.
opinion of your HOD.
I think
Dr.
Roshan is going to...
one of them is observer training.
I think
Madam will agree.
there is a knowledge, we should be able to pick it up, whether it is India or abroad. Yeah, Dr. Thakur has some
Just one question, just one comment, just one comment. I think I agree that every debate is successful if it is heated, and that is what has happened. But I agree with Dr. Chetan's comment that KM Hospital is a treasure house of clinical material, but that is underutilized. The second thing only is, in the modern world, for everybody, the choice is wide, but it has to be wise. If you do that, you are the best clinician and professional. Thank you.
I would say that everybody in the audience who have gone abroad have learned something and come back here.
Absolutely,
So
absolutely.
otherwise, people would not go abroad.
In fact, that should
If
be
there
the
is
rule.
nothing
At
in
least
it.
for 3 months training should be there for
It
each
gives you
person.
completely different
Yes.
perspective.
At least 3 months
Your
training.
approach changes. Everybody
Absolutely.
learns and makes a difference to the treatment here when it is given.
Kantaria sir.
This is regarding 2 points. One is regarding the research work and publication, and second is regarding the clinical training what we get abroad and India. I think we as a teachers in India, we have variety of patients, many patients and talent, full of talent here. Most of us must have been abroad some time to take some kind of a training. Now saying that the research and publication work is not good in India, I don't agree with this, first point. Because we as a teacher, if we take efforts to train our students, not in first or second year, but at least when they are third year, when they are SRs, we can definitely train them in publication work, one thing. Second, the clinical knowledge which we have here, in nowhere else we can have that much clinical patients and workload. So I think we have to have a balance of that. So it's individual doctor's choice whether they want to go abroad, and I totally agree with Dr. Roshan Wade. People who want better lifestyle, good amount of money, they prefer abroad. But those who are dedicated to their work and are satisfied with their work, they stay in India. So I'm proud to be an Indian doctor. So I'm really proud to be an Indian doctor and an Indian student.
Everybody is proud to be Indian doctor, okay?
Let us say that all of us here are very proud to be Indian doctors.
Yes,
Absolutely.
yes.
Having said
But
that,
we should not praise the abroad, those who get training abroad. Even we have gone abroad. The best things which we can pick up there, we can implement them here and try. It is the teacher's duty to train the students. We cannot say that the student keep on going and attending the classes because we are not taking efforts. They are going away and they are running away.
Dr. Neelam,
That is what is my observation is.
We got what you said, but tell me, having said that, you are here in GSMC last
How many?
Listen, now let me talk. So now you are here since 10-15 years. Every year, how many students out of 200 approach you for research? Tell me honestly.
That is because
how many approach you?
Sir, that is where we are lacking as teachers.
You give me a number.
Sir, we are lacking.
No, you are one of the good teachers.
How many
so how
teachers?
many approach you?
So I will ask you the same question. How many teachers are taking efforts to train and motivate them in research? How many teachers?
I will come back.
Can I reply to Dr. Neelam, please? Very good comment from you, Neelam. What most important, what you said, that everybody does the research at KM. Even I agree. I have done more than 100 publication in KM. Okay. So, but where is the initiation? When I went for some training, I came back. I found that ignition in me.
I had
and then
good teachers,
another
including
thing.
Dr. Sanjay Aksal, who
Another
had
thing. Just a minute. Let you say, I think your time is up. Let me speak. Second thing. You said we do the research. But the quality of research we do not have that quality. Be pure with your heart, okay? What research comes, or innovation comes, or robust research comes from Western, that we follow. We are not the methodology, whatever the formulate any guidelines. We are not the one who formulate the clinical trials. We should be there somehow, okay? What I mean to say by my conversation is, we have to be there as a conversing and formulating the guidelines.
Charan samadla.
Thank you so
Madam.
much for your comments.
Further discussion in Gurukul.
Dr. Kantaria, at which stage of medical education, undergraduate, postgraduate or postdoctoral fellowship, to the most significant advantage of students pursuing education abroad, in your opinion?
Yes. So that depends upon with what motive you are going. If you are going off with a motive to settle abroad, then it is better you go post MBBS. If you want to come back again, then I would say you do your masters, train yourself there and come back here, and then again start. So it all depends upon with what is the motive behind which you are going.
Okay. Let's move on. The next question is to Dr. Hetal Marfatia. How do the postgraduate opportunities such as specialization options and residency program differ for medical graduates in India versus those trained in abroad?
The specialization is a very long journey there, because nobody gets into specialization unless they have done 1 or 2 years of research, and it is already filtered at that level that which specialty they will get it. So it is not like what we are doing it here, which is a very clear-cut road as far as the Indian education is concerned, because you do your masters, then you decide whether you want to do any fellowship or you want to do any super specialty. So again, all the people who are doing masters will not pay attention much to their patients, but MCQs, because they have to get into the subject they love. So that is where their training is suffering.
The next question is to Dr. Charan. How do medical degrees from Indian institution compare with foreign degrees? Like if you train abroad and you come with a degree, how does it matter in terms of global recognition, your employability and career opportunities?
Again, very interesting question. I think again he is biased with me, so I will just reply in a short. Compare that.
Charan has bribed the moderator, so all the questions are going to Charan.
Compare that most of the people we have attended the conference, international conference as well national conference. When any international speaker comes, the whole crowd, full hall is full. And when an Indian doctor is presenting something data, hardly 10 to 15 people are inside the hall. Rest of them are in the food and they are eating something or chit-chatting. That's how the difference is. Globalization of what...
If I have to answer your question very simply, if there are two candidates with same skill set, but with one having a training abroad, whom will you employ? Whom will you employ?
Employ.
Same skill set.
So it depends on the specialty. If it is a surgical guy, I'll employ the guy who is trained in India, because I'm very sure about the skill. If it is a non-surgical field, you can employ anyone.
No, Dr. Roshan. Same means somebody who has worked here, got his masters here, gone abroad, come back here, he's appearing for interview, same skill set versus one who has worked here, whom will you employ? Be very honest to you. And if you are the owner of the hospital, you ask me whom will you employ?
One question. I think Akash will be better to answer.
Definitely Indian, because the Indian guy will come back and he'll get trained here because he has not got any training. You think the whites, the Goras will allow you to cut knife on their skins?
The question is not about Goras and blacks.
The skill training in abroad is just an observership. If you go for a 1-year fellowship, unless you clear your MLE, they will not allow you to touch any patient in America. Unless you create PLAB or the FRCP, you will not be allowed to touch any patient in the UK.
Right.
So it's an observer training. It is not at all a skill-based training. What they do, they just take degrees, they come back and they practice here like what Dr. Charan has done it.
Let's
have a comment from Dr. Ranjivar.
The thing is, there are branches, okay, interventional branches and non-interventional branch. I think Roshan has not done his homework on that. He has to do his homework, what is intervention and what is not intervention. So whenever there is an intervention, you have particularly do those number of cases, primary and secondary. Then only you get the certificate of doing the cases. It is assessment duly. So in India, it doesn't happen that way. You are neither see how many cases over the year you have seen as a primary operator and a secondary operator. That is one. Coming back to his question, as Dr. Chetan sir has already asked about, if you are foreign trained, if you have done some fellowship outside, coming back to India, see the multi-corporate hospital ka advertisement, okay? Any hospital, who gives the appointment, who gives the employment, corporate hospital.
That's marketing. They want MLE or US qualifications. So marketing.
So why do they give it?
Marketing.
That's not a marketing.
It's come on. People who want it, not the people.
It's a skillful thing which everybody can't do that, okay? So there has to be some addition to that. So everyone, suppose Akash, I think he has done interview, whatever he had gone for fellowship, including myself, everybody on this chair had gone for a fellowship. They had good opportunities outside. They have got attachment in a better hospital with a better fee. So definitely there is no discussion on this, whether you will get a job or not. Definitely we have done a foreign training, some kind of training, either fellowships, 1 year short training will be better in any kind of job opportunities. Thank you.
Next question, Dr. Roshan. This question is not to Dr. Lanjewar, but to Dr. Bhushan Thakur.
Yeah, thank you. I'll pay for it.
What are the challenges do graduates from foreign medical schools, particularly the Indian students returning from countries like Russia, Georgia, Seychelles and Ukraine face when seeking licensure and practice rights in India?
First, Russia, I'm very sure
This is to Dr. Thakur,
they must
please.
have enjoyed their life in Russia.
Let's not go there about the enjoyment in Russia. We are not here to talk about that.
Yes, definitely there are challenges. We Indian are facing the challenges, obviously.
Dr. Wade, please don't pressurize.
There are some regulatory challenges for this abroad medical person, like our NMC Medical Commission verify their degrees, recognize their degree as a part of this procedure, and this is a very tedious procedure and bureaucratic procedure, but they have to do that before their certificate confirmation. Second is to give the equivalence certificate to that Indian level degree initially. Then third one is their registration and their licenses with the national NMC, National Medical Commission, as well as whenever they are practicing in particular state, then that particular medical council also give the license for their practice. Then later on, challenges regarding their knowledge. As whatever you have mentioned, this Russian, Seychelles, their knowledge of exposure is very less as compared to India. That's they have to come and just whenever they apply for their practice in India, they are under some time they are under observership or some internship. And last issue is regarding their language problem. They are definitely don't know about our local language in local state, or they don't know about the Hindi. They are always know about English. So this is a big problem. And last one, documentation is the one of the huge problem for all the certificate required for this procedure with their transcriptor and everything required for their practice in India.
We'll take one question from Dr. Akash.
Yeah, so I had again a point to make. So when we compare the training here and training abroad, one key aspect is everywhere we are maintaining logs. So you are supposed to do at least X number of procedures to get certified that as a resident. For example, in transplant, you have to do 20 transplants as first surgeon and at least 20 transplants as second surgeon. And it has to be really the first and the second transplant surgeon. And the onus is on the mentor to ensure that you do it that much. Unlike here, where at times, the log is being filled one day prior to the exam, because next day you have to submit the log to the examiner. So when somebody from abroad comes with a certificate saying that he has done X many procedures, then you tend to believe, okay, that he has really done that many procedures. Whereas at times when you have people from India, you are not really sure. You have to call up and confirm from the mentor whether he has really done that many procedures or not.
Excellent.
Hello. Yeah. This is my personal experience. I'm from KM. I finished my anesthesia, DNB anesthesia from KM. I did 2 years in Tata Memorial Hospital. After that, I went to Australia. Now, this is Australia where, as Gora and all those things and the racial thing and everything we talk about. Now, when I went to Australia, the first thing, on the second day of my day in Australia, a South African Gora, as we keep on saying, he called me, he told me that your experience is such good experience in such good hospitals that we feel that the offer that we are given to you is very less. And he increased my pay. Now, this is just money wise I'm talking. On the second day of Australia, he increased my pay by $2,000. So that is the thing that they appreciate about India. That is one thing. Second thing about it is, after working there and after seeing my working acumen and everything from Tata and KEM hospital, they asked me to apply to the Australian board. And I applied to the Australian board and they exempted me from their primary and secondary examination. So that is the another thing, that they understand our working also, our experience also, and our training also.
In short, they keep only the good people and send back bad people.
No, remember this. No. Just listen to this, what I'm trying to say. Just listen to this. So I was the first person there without primary or without secondary was allowed to practice as a practitioner, as a fellow in intensive care unit. So I did 7 years of critical care in Australia on this. So I'm not saying that India is good or India is bad or Australia is good or Australia is bad. It all depends on how you train, how you are seen by the other people, and never ever say anything bad about anyone unless you experience that person.
Very
so
nice.
that is what I am trying to say.
Very nice.
True. I just wanted to make some comments. Like should not miss the forest for the tree.
Excuse me, can you identify yourself, please?
I'm Dr. Saad Ahmed. I'm working as an assistant professor in the Department of ENT.
Dr. Praful Samant from KM Hospital.
Thank
I think Chetan knows me very well.
Dr. Sami, are you practicing in India or Australia now? What, Dr. Wade? He has also come back.
He's come back with money. He's back with the full of balance, power, money, everything.
He's a good doctor who has come back to India, so not that they are retaining everyone there.
He's completed his youth in Australia. Now he's come back for his retirement. Retirement.
Dr. Saad, yeah. Thanks, Dr.
Thank you, sir. Thank you.
Dr. Saad. First, I would like to say that the GDP expenditure on our healthcare is abysmal. It's very less. So even after this, the bureaucracy has so many problems. So while running the hospital, sometimes we as doctors have to take over and see that the patients are being managed properly. After doing so much of headache, we are not left with the time of doing any proper research. And even the research that we do is not a very quality research. It's mostly case reports or small publications. It's not like a randomized controlled trial or in a peer-reviewed journal. The quality of research is abysmal out here. And also, because of the monetary support that we do not have, the research does not develop out here. Also, if a person wants to stay at KM hospital or some other BMC hospital, there are no posts. Like if I go to US or Australia, there will be posts for me created. But if I as a person want to stay in this hospital and contribute to it, there are no posts for me. Also, I feel that MCQs have become a part of a clinical practice and for the postgraduate exam, for the undergraduate exam, for the super specialty exam. And we have to understand that and inculcate these in our students and teach them about it. Rather than always saying that students are not coming for the clinical rotation and they're not learning. But we as teachers should also know that since MCQs are important to them, how we can inculcate the MCQs and help them out. Also, I feel that teachers have to put more role. There are teachers in other departments which do not grant leave to the residents, who use the thesis to twist the hands of the residents and not give them the proper rights. So when we are speaking about quality of life, if we are not able to give leaves to our residents, then what quality of life are we talking about? Thank you.
Thank you so much. Thank you for your input. My next question is Dr. Shenvi, madam.
I just want to make a comment that if we consider an MBBS student or for that matter MS, MD or surgery, medicine, gynec, whoever, they are having more clinical skills and more acumen when they are trained in India as compared to abroad because of the sheer workload and the experience and the exposure they get. But whenever there is a new thing, for example, if we consider few years ago, then there may be the situation with minimal invasive robotics or transplant surgery, for which the training is not available in India, then certainly one has to go to the foreign countries and get trained and then come back and then learn here. For example, if I think of getting myself trained in liver transplant surgery, or if somebody thinks of getting trained in liver transplant surgery today, few years back the situation was one has to go to foreign countries and get trained, but
So,
now
I
today,
get your point that we are lagging in
India
innovation
is
over
one
here.
of the biggest hub where living donor surgeries are done far more in number than the Western countries. So if the situation like that, till the situation like that arrives, we have no choice but to get trained abroad. And I expect the institutes here, like KEM Institute, to promote and send those who want to get trained in such situations.
Thank you for your comment. Thank you. Dr. Shenvi Madam, should India have targeted policies to retain medical talent in India? How such policies can balance personal aspiration and national need to retain the medical talent in India?
I feel that basically to retain in India, the work environment and the infrastructure of our all hospitals and colleges should be changed. Then definitely people will stay here, and in fact what they are saying that go abroad. If government takes an initiative of arranging workshops here for training for our postgraduates, that will be the best thing.
So if I say brain drain, can
And
be
policy
Is not able to appoint people full-timer.
No.
From 2009, there is no
So
full-timer
brain drain
appointed.
can be stopped by, one is providing a good working environment, infrastructure. Second is training the teachers, which is happening now. And reforms in curriculum, which is also happening now. Employment, better payment, sabbatical, good facilities for research. If all these are provided, there is no reason why people should go abroad.
No mental torture.
Biometric.
Work environment.
And regularization.
Dr. Roshan, your thoughts on, you have already said this, but
I
I
have
would
said,
like,
I think as an organizing
What are the
secretary,
factors?
I want,
Yes, one last question.
we want
What factors
time
you
to be
think
followed.
are the most important? That is that lifestyle improvements, high salary prospects, or superior education quality that our students are aspiring to go outside? Is it because of better lifestyle, high salary, or better education quality? What is the main aspiration for our students to go?
I have many friends who are trained in America or England. None of them have gone for training there. They've gone for money. So the brain drain, the basic reason for brain drain is money. If you don't give them money, people will not. So the moment you increase the professor's salary to 7 lakhs or 8 lakh or 10 lakh, nobody in the hall will join private practice. Akash will also come back. Money drives. See, science and economy has to go hand in hand. When you talk about science and economics, it has to go. See, that is the reason why after 12th, it takes a separate path. So the scientific research is always money oriented. And coming back to the publications issue, publications in today's world is salami publications. The wheel cannot be reinvented every day. You look at the publications, some of them are worse than a tissue paper.
Yes.
So publication is a landmark which is created by these Westerners to deviate, to ridicule you. That I have 2,000 publication, I have 100 publication. Out of that, only 1 or 2 will be a valuable, rest all will be slice. One patient is equivalent to 100 patients.
I think in this debate, none of us should give that message that publication is a dustbin.
Dustbin
It
nahi,
should
tissue
not be
paper.
the- It
Dustbin
should
nahi,
not be
tissue
the
paper.
message from us, from the dais here. Sincerely, I feel that. Another thing, if you give to 1 to 10 marks, your question was, I will give more marks to the balanced life. You have to balance your life, better infrastructure, better education quality, starting from 10 to 1. That's how it should go in that sequence.
Each panelist, sir, can you give your final thoughts? Final thoughts. He has already given his final thoughts.
So everybody has a different demand. This gentleman wants peace of life, he wants money, she wants pleasure, they want peace of mind, I want lot of money, and madam wants freedom.
One final remark from everybody, please.
Madam, last word.
Last word.
Final word.
Final remark.
Our work environment and supporting staff and our requirements for having a good environment should be followed, and then the people will be great teachers.
Implementation, proper implementation
I think
and
we should-
assessment can improve
I think it was
health
a
system
great
in India.
debate. It was
It will continue, it will continue. We have a,
So ultimately, the choice between pursuing medical education here and abroad, it depends on their personal choices, personal aspirations, financial capabilities, and ability and readiness to adapt to the foreign infrastructure, social and cultural differences. So each of the path, like whether you want to train here or abroad, it has its own challenges and it has its own potentials. So I am sure that all of you aspiring students who are sitting here must have taken something take-home message from this debate. And I thank all my panelists for great wholehearted answers.
Wholehearted, blooded debate.
Discussion, and I thank all the
Only wrestling is remaining. Only wrestling is remaining. Next year we are going to have a debate in boxing rings.
Let her ask the question now.
Thank you.
Good afternoon, I'm Dr. Hiteshi. I just wanted to say that nobody is debating the quality of medical education that we get in
Exactly.
India. But the fact of the matter is that, and I'm speaking from personal experience, is that majority of this brain drain that happens is because ultimately after struggling for years, you don't end up getting a seat in the choice of your PG specialization or the college that you want. So a lot of my friends and colleagues ended up going to a foreign country because it was easier for them to obtain a seat over there, which is a major problem that we need to solve at the baseline.
Thank you very much.
That's because of the extreme competition that we have here.
By the time we finish our felicitation program, I request the other panelists to reduce the number of time spent. I'll request the moderators to...
Thank you all dignitaries of the dais for having such a highly interactive session with the brainstorming.
We'll decrease the lunch time now, so quickly move to the hall, finish your lunch and come back.
Having the mementos, please stay on the dais, please. I request Dr. Kavita Joshi ma'am to please felicitate Dr. Dhangauri Shenvi ma'am. I request Dr. Kavita Joshi ma'am to felicitate Dr. Roshan Wade sir. I request then Kavita Joshi ma'am to felicitate Dr. Bhushan Thakur sir.
Now the video.
I request Dr. Praveen Shinde sir to felicitate Dr. Hetal Marfatia ma'am. I request Dr. Praveen Shinde sir to felicitate Dr. Chetan Kantharia sir. I request Dr. Praveen Shinde sir to felicitate Dr. Charan Lanjewar sir. I request Dr. Roshan Wade sir to felicitate Dr. Kavita Joshi ma'am. I request Dr. Charan Lanjewar sir to felicitate Dr. Praveen Shinde sir.
So, a message for my friend Charan, who is a very good and dear friend. हमसे लड़ने की हिम्मत तो जुटा पाओगे, पर वो कमीनापन कहाँ से लाओगे?
Thank you very much. Now we can go ahead towards Steve's lawn for lunch. We will be having the next panel discussion on institution versus private practice at sharp 2 p.m. Please be on time. Once again, sir is coming. Chetan sir. Thank you, sir, for having such an interactive session. Thank you, ma'am.
Hello. We request all the panelists to be settled in the auditorium. We are starting the session in 5 minutes.
What to do?
We can start. We can call Roshan.
He's coming, not coming.
Roshan is there.
He is not coming.
He's come. He's having his lunch, but I think he might have left for a surgery. That's what I feel. But it's okay. We'll handle.
Yes, yes, I know.
Our mics are going to be there.
Yes, you'll be given.
And mics, they will give. No?
Yes, yes, they will give.
Start.
Sir, Nitin sir is not. Huh?
I called him. His phone is not reachable. So we'll call Roshan. माझा फोन व्हॉइस मेलवर चाललाय. एक असतील तर आम्ही रोशनला मेसेज. I think by the time we start.
Nobody is come, no audience. Yes, yes. सर एक फोन कुठे बसणार आहे चालू करणार आहे ना अभी तो सर आएंगे ना अभी सब आएंगे
मॉडरेटर बाजूला घेतील मॅडम. हे संदेश सरांनी सांगितलं. इन्स्टिट्यूशन तिथे
We resume for the next session post lunch. Choosing a right career path is always a dilemma for medical graduates. After residency, working at an institution may seem like the logical next step in the medical career. But hospital employment isn't the only option. Depending upon your long-term goals, launching into private practice may be the best fit. There are differences as well as similarities when we compare the two general categories of practice. And often the line between the two models is unclear. The current panel discussion, institutional versus private practice, attempts to bring the clarity on the same. For this session, I would like to introduce our moderators, Dr. Aditi Fulpagar and Dr. Alok Patil. Dr. Aditi Fulpagar is Associate Professor in the Department of Obstetrics and Gynecology. She is an operating faculty at many national and international workshops. She has numerous publications to her credit. Her areas of interest are high-risk obstetrics, operative laparoscopy, and hysteroscopy. The next moderator for this session is Dr. Alok Patil, Assistant Professor in the Department of Occupational Therapy. He has a fellowship in cardiac rehabilitation and is also a SAIT GS Medical College FAMER Fellow. He has undergone many postgraduate certification courses in occupational therapy. His areas of expertise are in plastic surgery, musculoskeletal, cardiac, and stroke rehabilitation. I welcome both Dr. Aditi Fulpagar and Dr. Alok Patil on stage.
Good morning, everyone. At the outset, I would like to thank respected Dean Madam and Staff Society for giving me this opportunity. I welcome you all to today's panel discussion on institutional versus private practice. Myself, Dr. Aditi Fulpagar and Dr. Alok Patil will be your moderators for the session. As we gather today, the healthcare landscape in India is undergoing a significant transformation. With the growing demand for quality healthcare services, the debate between institutional and private practice has become increasingly relevant. On one hand, institutional practice offers the benefits of medical education, standardization, and access to advanced technology and resources. On the other hand, private practice provides the flexibility and autonomy and financial freedom that many healthcare professionals crave for. So, we have esteemed panelists for our session today. For the institutional practice, I would like to welcome our first panelist, Dr. Sandesh Paralkar, Professor and Head of General Pediatric Surgery. Dr. Sandesh Paralkar has many publications and presentations to his credit and is an excellent surgeon. I welcome Dr. Sandesh Paralkar as a panelist. Our second panelist for the day is Dr. Shilpa Rao, an eminent figure. She is a professor and head of breast services in General Surgery Department at SAIT GSMC and KEMH. She has 25 publications, 50 plus presentations. Ma'am has, to her credit, first multi-speciality breast service center in a medical college in Maharashtra. She has also delivered Essicon Oration, which is a landmark innovation trial by MCGM. Now her areas of interest are equal healthcare for all and creative intents. I welcome Dr. Shilpa Rao, an enigmatic lady on the dais. Big hand for ma'am. Our third panelist for the institutional practice is Dr. Smriti Bajpeyi Tiwari. Can we have Dr. Smriti on stage? She's there. Dr. Smriti is Associate Professor in the Department of Medicine at St. GS Medical College. She has been awarded various prizes. V.G. Rao Prize for highest marks in PSM in MBBS student. She has been awarded Service to Humanity Award in Public Healthcare System by MCGM in 2015. She has also been awarded with Minatai Thakre Gaurav Puraskar for her contribution during COVID. Her areas of interest are infectious diseases, HIV, infection control, and medical education. We welcome Dr. Smriti Bajpeyi. I hand over my mic to Dr. Alok Patil to introduce our panel for private practice.
Our next panelist is Dr. Akash Shukla. He is a MD/DM gastroenterology doctor, head of Department of Gastroenterology at SAIT GSMC and KEMH, and director of hepatology, Sir H.N. Reliance Foundation Hospital. His key achievements are numerous. He is a member of the Global Guidelines Panel, first author of Asia Pacific Guidelines for non-cirrhotic portal fibrosis, former member Steering Committee Vascular Liver Disease, author of 3 textbooks, 8 chapters, 146 publication, nodal officer for Center of Excellence at KEM Hospital for National Viral Hepatitis Control Program. Numerous awards include International Achievers Award Dubai 2017, Young Gastroenterologist Award 2018, Plenary Award 2018, and rated as Mumbai's top doc in many magazines. Welcome Dr. Akash Shukla. Next is our next faculty panel member is Dr. Nitin Dange. He's MBBS, MS General Surgery, MCH Neurosurgery, OBNI USA, FFHU Japan. He's a professor additional of neurosurgery at LTMMC and GH, consultant neurosurgeon at Leelavati and Global Hospitals, over 40 publications in national and international journals. His awards honors include APJ Abdul Kalam Excellence Award, Multicon International Award in Medicine and Surgery, Award for Best Young Neurosurgeon, and other recognitions. He is life member of Neurological Society, Skull-Based Society of India, Indian Stroke Association, and founding member, Society of Neurovascular Intervention. His areas of special interest are many, some of which are endovascular, skull-based, and minimally invasive neurosurgery. welcome Dr. Nitin Dange sir on the stage. Our next panelist is Dr. Ujjwal Rathod. He's MBBS and MD, Professor Additional at SET, GS Medical College and KM Hospital, Consultant Pathologist at Ganga Diagnostics Center, Chembur. He has 8 publications and first prize in Epicon 2006. His area of interest include GI pathology. Dr. Ujjwal, welcome.
So with our esteemed experts from both sides of panel, we set the ball rolling.
Hello, check.
So we have divided our panel discussion among 3 rounds. So we are now beginning with our first round, where we will be asking questions to our panelists, and they will be answering in a minute. So my first question goes to Dr. Akash Shukla. How do you think the work environment differs between institutional and private practice settings?
Thank you, Aruna, for that question. So in private practice, you are your own master. So you decide the environment, you create the environment. So you are basically the whole facilitator of the type of environment that you want to develop. Whereas in institutions, if you are a resident, then the working environment is decided by your seniors and the head of the unit. If you are the professor or head of the unit, your environment is decided by the head of the department. If you are the head of the department, then the working environment is decided by the dean. And if you are the dean, your work environment is decided by the municipal commissioner or the assistant municipal commissioner. So it varies according to the situation. If you are in a private institution, your environment is decided by who is the management, and whether the management changes, the work environment also changes. So there is no consistency if you are in an institution.
I think the corporates play a major role in private settings.
Absolutely right.
The targets which they are set by the corporates.
Absolutely. So the environment will change depending on who is the management if you are in an institution. So that is what governs. Whereas in private practice, you are your own master.
So my next question is Dr. Sandesh Paralkar. So what strategies do you employ to ensure high quality patient care in your current practice setting?
Good afternoon. Hello. Yeah. Good afternoon, everybody. I think it's a very interesting question. In the current scenario, what I follow in the department is small steps at a time to have to improve the patient care. Infrastructure-wise, I think it depends on each head of the department to have enough infrastructure. Two things which I would like to mention is cleanliness and communication. Cleanliness, I think our Dean Madam has shown that what can be achieved when she cleaned the entire campus for this particular event. And it also depends on the individual HOD to ensure that the cleanliness is maintained in their own particular departments and going beyond their department to the extended parts of the department. I think communication is very important. Communication not only from doctor to patient, but also from doctor to doctor, doctor to nurses. And most of the issues that we face nowadays are lack of communication or miscommunication. In spite of IT development and social media that we have, or whatever gadgets that we have, we see a lot of miscommunication or lack of communication even between the residents of same batch. or between faculty members in the department. So if these two things can be improved, I think we can improve our patient care in our own institute, which will be comparable to private sector. Private sector, I have to admit, has a lot of glamour. And we can't do anything about it right now, but we can only hope to improve. One question, one sort of remark that everybody makes when they give me a call is that a patient affording nahi hai, iske liye tere paas bhej raha hu. And I hate that statement. I hope when I leave the department, the patients will come in spite of whatever financial status they have or whatever background they have, and they will choose KEM hospital over any other private hospital. Thank you.
So about what you said about glamour, I would like to say if we keep on having programs as lit as this, we would soon be matching the glamour quotient of the private practitioners as well.
The glamour is, I'm sure there is a lot of glamour over here right now, but I'm talking about glamour in a broader sense, and probably in the eyes of, in the eyes of general public, even our residents to a certain degree. I will tell you another example. I was in Jaslok after my MCH, and I did a clinical assistant course for 6 months, and then I took over, I took the job of assistant professor at Nayar Hospital. Almost entire family, my own family kept asking me, "Arey kya Jaslok mein continue karne ko nahi ho raha hai kya, Nayar mein kyun ja raha hai?" So glamour I am talking about is in broader sense, not just the narrow meaning of it.
I think, Sandesh, I take offense to that. When you're talking about glamour, the glamour is in that sense also. I think we are pretty much leading on all fronts of glamour in this institute, whether it is
I
personal
think
or otherwise.
heartiest congratulations to Dean Madam for arranging this conference at such a big level where we are matching all international standards out here. So that is no less than a glamour in terms of academic excellence.
And I think she epitomizes glamour in person, in administration, and in whatever. So I don't think we are lacking anywhere in glamour in this institute.
I also got to know her secret that she orders a sari every night before she goes to sleep. So probably that's the reason she doesn't repeat her saris.
Okay, we'll come back to the next question, which is for Dr. Nitin Dange. So can you share an experience where collaboration between institutional and private practitioners led to better healthcare outcomes?
And so as you answer that, also let us know how do you ensure that your patients are really, really safe?
I hope you got the pun. SAIF.
So good afternoon, and first of all, thank you very much for inviting me here. Though this is my, 20 years I am here, and now I'm shifted to Sion. But having said so, it's a very wonderful change I can see here, because I've come today after this beautiful program and with infrastructure as well as the way arrangements are made for this event. I really congratulate from bottom of my heart to everybody, including Dean Madam, for this wonderful event. More so, arranging such academic discussions is the key highlight which I feel is only possible at institute levels. So, what are the incidences, or one of the very common example I can share here today is how collaboration worked with the patient outcome, and what Sandeshji was talking now, it was not an appropriate word talking about glamour. What he meant was branding. So that was the basic thing what he was talking about, and what he mentioned, I feel so. So when we inaugurated our stroke center, which was called as a comprehensive stroke center in 2019, there was lots of this thing about it, that in institutes having good infrastructure and state-of-the-art facilities. So that made a huge noise all over the world. Some WhatsApp messages were moving around which was not appropriate, not framed properly, but the sense was awareness created of mechanical thrombectomy up to 24 hours. That made a huge impact in the society today. And I tell you, with that, now people are installing new cath labs and they say KEM model. So imagine this is what collaboration, the experience and the infrastructure as well as the branding which can make a difference. Another example, after inauguration of that unit, I got a call from the justice, a senior justice from our High Court. He said, I want to do my procedure. He needed a brain stent called flow diverter and I want to do it with you only at KM. I said, sir, why? You can come to Leelavati, you can go to any other private practitioners and do it. So he said, looking at the empathy, looking at your zeal to treat number of patients, your expertise and the new infrastructure, I am happy to compromise on the post-op care or the room and something like that, but I will still like to get it done from you. And we did the procedure in 2019. He is hell and hearty, and luckily today I'll just tell you the follow-up. Now he has become the Chief Justice of Chennai, and last week he came for a follow-up angiography. So these are the examples which really, with collaboration, with setup of infrastructure, can make a difference, and this is one good example.
Thank you, sir. स्टूडेंट का, टीचर का, पेशेंट का, सबका क्वेश्चन लेगा ये मॉडरेटर. ताली बजाओ. My next question is for Dr. Ujjwal Rathod. Sir, what do you think? How do the regulatory frameworks impact your practice? Are they differ? Do they differ between institution and private practice?
Yes, to regulate the framework practice, you have set up the strategy and protocol for the patient care. Like you have to do the quality control like HMIS and accreditation for the patients. And there is a huge difference between the private and I had seen that in the private practice you can set up your own equipments and good tools. You can buy your good tools and the equipments for the patient and you can keep the, like I have seen that we are struggling for the HMIS in our institute, we are not getting, and we have to buy the low L1 quality of the equipments. And second most is you have to compromise the ethical practice in the private to get the monetary benefit. Like I am as a pathologist, unless I paid huge deposit or cut, so I will get the less likely I will get the referrals. And third most is you have to, I had seen most of the people do the practice but they don't surrender their NPA. My advice to them is like that, you surrender your practice. तुम्हारा भाव बाजार में ही पता चलता है. Unless you leap into the water, you won't learn the
Sir,
swimming.
I would like to interrupt.
Yes.
Since there are authorities which are regulatory like NABH,
Yeah.
so those sanctions need to be taken prior, and there is something like a quality control also. So how is that maintained in the private practice setting? In terms of pathology, I would like to say.
That is maintained because of we are there are the companies are there. They are the private.
Since you said it's not the ethical practice is.
That ethical practice is different.
Yeah, so what is in between those lines?
Okay, that I want to pass. Okay.
I've got you there.
Next question is for Dr. Shilpa Rao, madam. It's about research opportunities. How do institutional and private practice settings differ in terms of research opportunities? And what are the implications for healthcare advancement?
Yeah, I think it's better. So Aditi, I'm going to take a little more than a minute, and I'm not going to make it about me, but I'm going to talk about a few I's. Okay? The first I, which is really important in terms of academic practice is infrastructure. We have such an amazing infrastructure and collaboration that happens here. I mean, if you have any issues, any problems, all you need is a phone call and we're good to go. The second thing, which I didn't agree with Dr. Lanjewar when he said that there are no innovations happening in India. Our department has done 2 innovations, one associated with the IIT on fecal diversion with Stanford University. That's commercialized now and available in the market. The second innovation is AI-based thermalytics, which is coming to market, which will compete with mammography and sonography. And I don't agree that there is a dean and there is an NC. This has come right down from the NC, the innovation cell of NCGM. And this is going to be a strong 6,700 patient database. And I think KM will set that trend. I don't think this is possible in corporate practice. And the dean was happy to sign. And I think it's only a question of want to do. And we're going to be there. The third thing, again, is the institutional ethics. Okay? For every multicentric study that is available in India today, it is not validated unless one of the academic institutions is part of that study. So that research is going to be incomplete without, the academic institutions such as ours. And my last point is integration. Whatever studies come out of corporates, they talk about a certain sector of people. They do not represent India in its wholesomeness. What comes to KM is India in its whole. Like whether you're Amitabh Bachchan or you're whoever, when they have it's an RTA, it's whatever, they will come to your institute first. And so we cater to all parts and types. And Dr. Rathod, bhav hamesha paise se nahi hota hai, bhav naam se bhi hota hai. And people come to KM specifically with the doctors' names. And we should be far more proud of that than any other bhav in this place.
I think the happiness at the end of the day counts. Those who work in an institutional settings, they will always, try to upgrade their medical knowledge. They will be happy teaching students. Even if they go home at 4 o'clock, I'm sure they have some better things to do. So only doing private practice in the evening doesn't get you glamour. Doing something for yourself or for your students also matters a lot. I'm on both sides, by the way, so don't take me wrong here.
The next question goes to Dr. Smrati Tiwari. How do you work on your work-life balance? What advice would you give to young professionals seeking to maintain a healthy work-life balance in either institutional or private practice settings?
Work-life balance. I would like to put it in a better term, which I always like, is a work-life harmony. As the saying goes, one cannot pour from an empty vessel. And we are working in highly stressful work. The workload which we handle, it continuously depletes. Am I audible? Okay, so it is continuously depleting the energies of physical, mental, spiritual, psychological, at all levels. And what I believe is, it's not an option or a luxury. Work-life balance is not an option and a luxury. It's a duty of a medical professional to maintain this. Because if we don't, all our energies are going to get depleted. They do get depleted every day. So we need to replenish it every day at all. Having said that, how does one achieve it? Now, it's easy said than done. Life, I feel, is a very big entity to say. It encompasses a lot of factors and lot of things in itself. And work is just a part of it. We need to understand that. So it is important that we give adequate time and priority in our minds to things like family, nurturing friendship, faith, meditation, timing out, zoning out. And please let me be clear, this cannot be when I am tired or when I am done with. It has to be continuous, everyday, ongoing process. before we land up into any burnout. So that's what my suggestion would be, irrespective of whether you're in a private setup or whether you are in a institutional setup. Work-life harmony is the duty of every healthcare professional.
Thank you. So what we are going to do is we are going to have one quick audience question at the end of each round. So as we end this round, if you have a question, quickly raise your hand. We'll just have one question for one speaker. Please.
Dr. Saad? Yeah.
I have a question for the panelists.
Can you name one panelist from?
No, just anyone.
Okay, please proceed.
So there are people who, during the working hours, working in an institution, are still doing private practice. How is that affecting the quality and skills of the future generations of doctors, and what can be done about that?
Any panelist would like to? Yeah, please.
Yeah, I think people who are in private practice will be answering this question. So the question by Dr. Saad is, what is the reaction on faculty who are doing private practice in duty hours? Is that what you mean?
And how does that affect the future generations' professional quality and their skills wise? And how are we training the future generations? Because the quality will keep deteriorating if that
See,
keeps
Dr.
continuing.
Saad, in an institution, when we are announcing private practice, that time the private practice always starts after 4 p.m. 9 to 4, we are supposed to give in writing a bond where we write that we are working in an institution from 9 to 4. And always the private practice starts after 4 p.m. And after that also, if there is any medical emergency in an institutional setup, we are supposed to always be available there for the patient care of the institution where we are working. This is our current setting.
So would you like to answer further to that? Or is it answered?
No, ma'am, that is ideal, but sometimes the ideal situations are not happening. I'm talking about those situations.
I understand what you're saying or what your apprehension is. I don't agree. I mean, I don't agree that it doesn't affect. It affects everybody. It affects the individual. It affects the patient. It affects the resident. Everybody. Most importantly, it affects the individual. So it should not be done. It is not allowed. Private practice is allowed, as I understand, only after working hours are done. And not only medical emergency, on medical emergency you will be called for. If the HOD or the dean thinks that you cannot go or certain work needs to be done on that particular day, then he or she better do that work on that particular day without giving any reasons. Am I right, madam? Dean, madam?
Can I add a sentence to this? It doesn't matter if you are into private practice or you're fully academic. It's an individual teacher which counts. So if as an individual teacher, I just sit there and heat up my chair and do nothing academically or otherwise, I'm not doing anything. I'm not for private practice, but also let me tell you that my colleagues who are in private practice, a lot of them are very inspiring teachers. So I don't think it is to do with the time that is put in, it is the energy and the dedication that you put into the profession that will ultimately make a difference.
Yeah, I agree to what madam is saying, that what she means is, to put it very simple, that you know, a 9 to 5 punch out or a 9 to 5 biometric doesn't make you a good teacher. And neither am I saying that what she said is, you know, people who are in private practice are not good teachers. If you are focusing on medical education to say. So, you know, let's not put boundaries to these things and not, you know, brag jacketing, you know, no, let's not do that. You know, I have my own experiences to share here. We have on the other side the HOD of gastro sitting here, okay, who would vouch by saying that the entire gastro department would say that he's one of the best teachers. And you know, he's trying to balance his private and probably the institutional practice as best one can do. So, you know, it's also our mindsets which have become like, you know, if you are in an institutional setup, you're bound to not do this or do that. So let's think beyond it, and there are people and examples there.
So I think making one available for any emergencies and any act for that point of time, even if you are not physically present, is what is important. So, as we are running short of time, we'll start with the round 2. So, my question is to Dr. Akash Shukla. How do institutional and private practice settings differ in their ability to adopt and implement new medical technologies and innovations?
So I think this is something where things have changed in the last 2.5 decades. So 2.5 decades ago, the public institutions, the government sectors, the medical colleges were the leaders in providing the latest technology, because only government could afford to invest in large capex, capital expenditures for buying latest equipments and state-of-the-art equipments. But over a period of last 20-25 years, things have gradually changed, and the standard of care, unfortunately, has started moving out of the public institutes to private institutes. And that is basically because of the ability to invest big-time money. And, in public institutions, you do get bound by a lot of rules and a lot of bureaucratic processes. So this is not to say bureaucratic processes are right or wrong, but it just takes time, and there are limitations to that. You are bound by the laws of the land, and you have to follow that, and therefore it greatly hampers the ability to adopt something which is come latest, which may not have multiple providers. You have an exclusive provider. So it does become challenging. Although there are individuals who have driven the change, and there are people who have managed to get these even in public institutions. But those are rare. Those are exceptions rather than the rule. Whereas in private today, if you want something and you think that this is what is required for my institution, I am not really bound by so many constraints, and I can get them much faster as compared to a public institution.
Are you happy with the infrastructure that has been brought to KEM after your experience in GI medicine department outside?
Yeah, so absolutely. So I think for me it has been a major, major change in life. When I had the option of coming back to KEM from SAN after being HOD at SAN, and before that spending 10 years as a faculty here, the only thing which drove me back was because I wanted to set up the liver transplant program here. I was already a part of a team which had done 700 liver transplants in private practice by that time. But it was my patients here who were lacking that. The other thing which was driving me back was, we were not able to deliver the highest end of endoscopy services in public sector. So things like third space endoscopy and all. So when I was doing these things in private, to get them in KEM hospital was possible because I knew what it took to establish these services. And there again, we had a very good collaboration between private and public institutions to get those things implemented. And thanks to Dean Madam, we got the donations, we got the infrastructure which was required, and in 6 months, everything that we required in terms of equipments, the ICU settings, the other staff, everything was ready, and we started a liver transplant program again in KEM hospital. After 10 years, we could do a living donor liver transplant program also started. So I think that was thanks to the leadership, and also because we had expertise available, external help also available, and that the experience that I had because of being part of a private practice program. So I think all those things came together for us to make this program successful. So therefore, I loved what Smriti just said, that we should not have these boundaries. I think whatever can get the job done for your common patient, for an average patient who cannot afford the private, I think it should be done here. And just because I cannot pay the money to a hospital doesn't mean I should be deprived of the treatment that I deserve. I think that has to be the goal of everybody who is working here.
Thank you, Dr. Shukla. So my next question is to Dr. Sandesh Paralkar. Sir, now it is about mentorship. What role do you think mentorship plays in the development of healthcare professionals, and how can institutional and private practitioners provide effective mentorship?
I think by definition, mentor means a more experienced person who looks after a less experienced person, not only in the professional part of his life, but also in his personal part of life. And the last thing is very important, at an interval of time. It cannot be at one moment and I'm your mentor and I will be there for 5 minutes and you are done with it. So mentorship is very important. That is what is encouraged and that is what is seen in institutional based practice. I'm sorry I'm not in private at all, so I wouldn't be able to answer how mentorship.
Sir, in private institutions, they run courses like DNB. So
Yeah,
even they are called mentors there. The medical teachers whom we have in the medical college, the same role is played by the DNB teachers in the private institutions also.
Agreed, but I think
This is for medical education.
Everybody will agree that the patient load in private hospitals is far less as compared to what we have in public hospitals, and the time that we spend in an institute like KEM, or if a consultant is not doing any private practice, is far more. It is not about only you can work beyond working hours, or you can compensate that after 8 o'clock or 10 o'clock, but it's a continuous process wherein your behavior from top down, it helps in mentoring a particular individual. What I tell my students usually is 40% of pediatric surgery remains same, 60% keeps changing. Maybe it is true for most of the medicine, but as far as pediatric surgery is concerned, I keep telling my residents that 40% of pediatric surgery remains same, the core, and 60% of it changes. What is more important are two things: how to be a good human being first, and then secondly, even if you are a surgeon, trained surgeon, teaching to operate, when not to operate is the most important decision that you should be taking. Because I think when I tell my residents not to operate, the entire onus and the responsibility is mine, that I am telling you not to operate, when I know that I have probably 15 faculty and residents under me who can operate and do a good job. Even if it is a negative exploration, nobody is going to ask me why was he or she operated. So that is my take on mentorship.
I'm sure all medical teachers out here will be happy that their students will remember their mentors for lifelong, and we get a lot of blessings from them. I would like to go to the next question. This is for Dr. Nitin Dange. So what strategies do you use to engage patients in their care, and how do institutional and private practice settings facilitate or hinder patient engagement?
I think so. It's very important part of outcome in patient care, engagement of the patients. The most important thing which can be improved, especially in institutes like ours here, is clear communications. So whatever we are taking decisions, whether it is a medical management decision or a surgical option or a non-surgical option, it is very, very important to engage the patient and the relatives, communicate clearly to them what their near and dear ones are going through, what are the modalities of treatment they are going to undergo in that particular institute, what is the problem, what are the ways of handling, and giving them options. So one is clear communication, then sharing the decision making. We have to engage them in such a way that they are happy to give their input to us to help us take decisions. So they will feel engaged, involved, and consider themselves as it's not the doctor is alone taking the decisions without informing us what's happening, and that enforces trust. That enforces trust into the treating surgeon or physician. That's a very important point I want to mention here, that clear communication, involving into what we call decision making, and education, creating educational videos about what the disease is. Maybe it's a media, maybe it's pictures, or some slides. We have to keep it ready because each department, each sub-speciality has their own ways of dealing with. So if you communicate and engage them, they feel involved. And if you involve them, the outcome definitely improves. For simple example, you are the best surgeon, you do your job well. But there are other factors post-operatively which are going to decide the outcome of the surgery, especially in critical care, neurosciences and other specialities where patients are critically ill, the ICU setups. It's not only the nursing care and the treating persons or the intensivists doing their job. They are doing excellent job. But if you're not engaging the family, they are not aware of what's happening, they are not well informed, what is the new technology has been utilized, we are getting that for your patients, they will be very happy to know that these are efforts done by the team to improve the patient outcomes. So this is very, very important, that clear communication, decision-making involvement of the relatives, involving technology, integrated technology is very, very important, that they are aware that we are not, though we are in a high volume center, but still we are utilizing the best technology to improve the human errors. So they will be very happy, and that would definitely improve the outcome.
So, talking about this, Dr. Smriti, these skills, how they have been imparted in the medical education setup since you are actively into it? Utilizing the...
Absolutely, I got your point. So what you're meaning to say is, how am I utilizing communication skills, how to communicate? As you know, we are living in a time, I would use this term which I would pick up from US military, which said that we are living in a VUCA world. V standing for volatility, U for uncertainty, C for complexity, and A for ambiguity. In this VUCA world, this is not going to give us simple problems. It's going to throw wicked problems with us. Same is true with medical education. Medical education needs to evolve with the time. The requirements of the time is this VUCA. You have to be constantly evolving. You have to constantly evolve as per that, and I'm very thankful that the curriculum has changed for the same. When we adopted the CBME curriculum, the plan was this. You know, you can't be teaching our next generation the way and the things which were probably not up to the day. You know, I know of my patients coming to me and telling me when I was in the initial phase of my residency saying that डॉक्टर लोगों से तो कुछ पूछने में डर लगता है, वो कुछ बोलते ही नहीं हैं, शांत रहते हैं, you know, and till today I'm seeing this, you know, अपने physician से they won't ask those questions, they're going to, you know, either Google it or message you that, you know, I have this issue, my doctor has prescribed me this, what to do. So these are the issues which my next generation of residents are facing. These type of questions they are facing. So we are updating our medical education as per the needs, and we are continuously telling them that communication skills is the key. Please don't hide things. Shared information. You know, when Dr. Dange said that the patient's relative should feel that you are a part of decision making.
Yeah, it just takes a minute to go out to the patient, explain to them. So because I am in a private practice also, I myself talk to the patient, I counsel them about pros and cons of surgery. After the surgery is over, I go to them, I show the specimen to them. Everything we have to explain. Even the patient care, diet and
Aditi, what you're saying is,
mobilization.
in medical education, we are doing this through role plays, you know, through examples. We are picking up, you know, movie clips. This is becoming a part of their training. You know, when what I'm saying is not just for the book's sake and for the, it's actually happening. And I'm sure we are seeing that change as well.
So I'm happy that our medical education is bringing in change.
My next question is again to Dr. Smriti Tiwari. It's about interdisciplinary collaboration. Can you share an experience of yours where interdisciplinary collaboration between healthcare professionals from different backgrounds and settings led to an improved patient outcome?
Absolutely, Alok. See, I don't have to look for any examples, you know. COVID, we all are living in the shadow where we have just recovered from COVID and we have seen. And I think so, when I said about the VUCA, this is what I meant, you know. Such wicked issues, such wicked complex problems. We were absolutely thrown into the sea. We had no clue as to what we are dealing with. And what actually helped us was this interdisciplinary collaboration. I remember that day when Dr. Hemant Deshmukh was the dean and he called us that we are going to have an HR department. The entire department, the entire college came up, hand in hand. We had no differentiation. Who's the surgeon? Who's the ENT person? Who is the gynec or who's the medical person? We all were together, and I think so we could withstand COVID, better handle COVID, and I think so I am proud to say that Mumbai was one of the pioneer cities which handled COVID the way it did. And that is because of this collaboration, because of the interdiscipline. I would go one point ahead, that we need not stop at medicine. We need to look at collaboration beyond medical professionals. Social entrepreneurs, government, policy makers, psychologists, social scientists, all need to collaborate. Only then we will have better solutions to our wicked problems.
Thank you. Next quick question to Dr. Shilpa Rao, madam. How do institutional and private practice settings measure and track quality metrics, and what are the implications for healthcare quality and safety? We are now just having 14 minutes with us, so request all speakers if we could have a really quick answer. Thank you.
Rolling? Yeah. So metrics by itself means measurement. And I think bureaucracy is one of the reasons that metrics is kept in place. Like Campbell's law says that the bigger the problem, the bigger the issue, the bigger the metrics, the more likely it is that you will skew it up. You will change it to suit your purposes. So it is probably the bureaucracy and the rigidity of institutions like this which make sure that metrics actually goes into social responsibility. So that is how I feel it changes. The other thing I would like to tell you is because we have such a large base and there is very little study on the Indian woman, because I had the breast services, there are no protocols in place for the Indian women with breast issues. So because we have such a large base and reference system today, we are able to set down protocols. We are able to make guidelines. We are able to connect with the government and with the universities to change the protocols and guidelines. So all that happens only when you have a solid metrics which then converts into social responsibility, which I think we tend to take seriously in academic institutions such as this.
Thank you for the quick answer. Next one is for Dr. Ujjwal Rathod. It's about burnout prevention. What strategies do you think are most effective in preventing burnout among healthcare professionals in institutional and as well as private practice settings?
To prevent the burnout, you have to learn the time management. Time management is the best thing which I have learned with the time. Like spending time, you can restrict your patient in private clinic, and you can spend more time with your family. And like I am involved in the many committee in the institution. Like I am vice president in Gymkhana cricket. I like to play cricket also. As every Sunday I am going to, I am always busy with the cricket match and giving time also my family.
Happy to know that.
Can I just add to it? And you should have a lot of friends.
Yeah.
I think that is important. 4 of us are sitting over here. 4 of my best friends are sitting on this panel right now. So, so I think having friends, chatting with friends, even at workplace, if you have friends, I think it helps a lot in preventing this burnout.
Yeah, privileged to know that. I feel very proud to be called as Akash's batchmate.
Same here.
So we start with the round 3. My question is to Dr. Smriti Tawari. She's also my batchmate.
Yeah.
What predictions do you have for the future of healthcare and how will institutional and private practice settings need to adapt to meet emerging challenges and opportunities?
Aditi, I'm going to, we know we have only 9 minutes. I'm no clairvoyant, but so I'm not predicting, but I'm definitely, what I see is what I'm saying, that there are 3 things which is very important in the Indian medical landscape which I see. First is, it is going to increase the tech enableability. Tech enable and not tech driven. Technology is going to be big time in, it's going to increase, and we need to be prepared in both private and public sector for the same. Second, medical education included. So technology, virtual learning, individualized learning is going to be the game changer for medical education. We have to be prepared for it, and we are already gearing for it. Third is, we cannot keep looking at the West for answers. We need to have made in India for India solutions. And fourth, which I would like to say, is that interdisciplinary collaboration, which I have already emphasized. And I would end by saying that the future lies in individual care, curated care, targeted therapy. So I would end by saying the future is tech, curated, individualized care, and medical education being strictly and seriously influenced by technology.
My next question is to Dr. Akash Shukla. How can institutional and private practice settings integrate and coordinate care to improve patient outcomes?
I think this is because with bidirectional exchange of ideas. I think people have to, again, like we have been talking before, we should just have no barriers. It should be a complete free flow of ideas. Similarly, there should be exchange of expertise. I think not everybody in both the sides will have equal expertise in every single thing. So people should be moving bidirectionally to provide the expertise. And finances, believe me, are only a very small part of the motivation for most of the people who are working, even in private, along with this. A lot of it is because they can get the opportunities to deliver what they are capable of when they are practicing outside. And backward integration, that means what you learn outside, you're getting back to the institutes, I think is the best thing that can happen even in the institutions like ours, where we can get in the best practices of private world into a public health system and leave aside the things that we don't want to bring in. So that is the best way. So we already have a very strong foundation here, very strong principles. We have the required empathy and the skill set to deliver most of the things. What that icing on the cake, what is missing, can be brought in by what you are learning outside. I think that's the best way to integrate.
Yeah, so striking balance at the end of the day is very important. My next question is to Dr. Nitin Dange. What role can institutional and private practitioners play in addressing healthcare disparities, and what strategies have been effective in your experience?
So, I think so all of us are discussing the similar issues, how we can leave aside our egos and the experts in every field, whatever are the disparities related to infrastructure and economics. For example, we are talking of a situation of healthcare sitting in Mumbai. We never see or understand what's going on just few kilometers away from Mumbai. So when we get referral from all over Maharashtra and neighboring state, or rather from all over the country because of some specialities, we have to realize there's so much of disparity. As every human being or every Indian, I feel, should receive healthcare to the best, whether he is poor or rich, and that is their right. So we should all come together, gather here, discuss how well we can provide infrastructure. So I always tell the bureaucrats, the decision makers in the politics, that there are 3 A's or 4 A's which are very, very important. One is awareness, second is availability, third is affordability, and accessibility. So all these 4 A's are the ones which each one of has to think over, work on it, contribute to address at least one of it, and make and improve over or bring the disparities down and make it a unified one, so that patient is a patient. Whether he is rich or poor, he is diseased. He should get the ideal treatment. That should be our goal. And that is one of the advantages I feel when we are doing in private practice. We realize how well empathetic we should be to the patients who are poor patients. I feel I attribute my learning, my confidence, my name today is because of I worked here for all these poor patients, and that has given me the success today, and I am thankful to them.
Thank you.
Yeah, I would like to add that such a great selfless service we are offering at KEM Hospital. I would give example of KEM Hospital OBGYN department, wherein all over Mumbai, Maharashtra, patients are sent with low platelets, bleeding placenta previa, percreta, creta and whatnot. Very high risk obstetric patients we are receiving. And with the excellent anesthesia department team we are managing, I'm very thankful to all the anesthesia team out here, Dr. Aarti, Dr. Pallavi, everybody, Dr. Amla, with the AICU care that they are giving to us. Like, we feel very safe. You know, just Shraddha tells me, Aditi, you operate, I'll manage her next. So this is what is, you know, a real example of interdisciplinary collaboration for me.
Next question is for Dr. Shilpa Rao. It's about telemedicine and digital health. How do you think telemedicine and digital health will change the way healthcare is delivered in institutional and private practice setting?
So let me take the telemedicine part first. Like Nitin mentioned, we only get, and like you said, we get very complex, almost patients with double, triple supports. So if we have telemedicine and we can have the conversation and we can tell them, you know, digitally, what could be done, what could be avoided, what could be possibly, you know, what is possible, maybe the complexities would reduce, and we would also be able to give equitable care, which is one of my passions, to people across India, because they don't have guidelines in place, they don't have protocols in place. But if we can do that through telemedicine, that would be like a win-win situation for all. And coming to AI, which everybody is talking about, and like Dr. Farooq Udwadia mentioned, AI cannot touch, AI cannot see, AI cannot feel. AI is very smart, and AI is competing with all of us. It's done wonders in the field of radiology, with no offense to the radiologists here or the pathologists here. But it still has a way to go. It is only what is fed into it. And one very important, it can give you multiple decisions, but one very, very important thing, like Sandesh told us, it will not tell us when not to intervene. And we are still winning against AI in terms of that. At least today, 20th of Jan 2025, yes, we are still here. We don't know next year what the scope will.
With regards to AI, I would like to say in past year or so, I am also using AI. So I feel, although it is artificial intelligence, AI, I feel it is rather a very intelligent assistant, IA. So if you use AI as an assistant who's always there to help you, it really works wonders. So we'll be dropping the last 2 questions we had planned for you for round 3. I'll ask Dr. Aditi to summarize the current. Do we have a quick audience question? Please, sir, could you approach the mic and ask your question? Sir.
I just have a comment. Both way, private practice versus the institutional practice. I am doing institutional and private practice the both way. So in a way, both words, if you are having the both words, that's the best for the individual. Just imagine when this private practice was sanctioned and on, this was basic purpose was to stop the brain drain. People were leaving the institutes, most of them, and that was the reason the private practice has come into the picture. So that purpose, since that day, nobody, most of the people had not left. Those who had the talent, those who are doing good are there in the system. So imagine this is working well for the individual, for the professional, and for the patient also. Another thing, patient care. You know, I agree with Dr. Ujjwal that when you go out, then you understand that we are not the only frog in the pond, okay? We always, when you are in this system, you feel that you are the only one. But when you go out, you feel there are multiple. And what Akash has mentioned, this is the exchange mechanism, okay? When you see out somebody is operating in a different private institute, you learn just by the observation. What we think that we are doing with the techniques, that may be the old technique what we are doing operating. But as you exchange the knowledge with other people in other institutes, we become better. I think that's the best for our patient care also, and that should be on. Thank you.
We can take audience question.
Yeah, just point to ponder. We spoke about mentorship, and when we speak about mentorship, we are talking about students and our juniors. And it all depends on where you are working. If you are working in an institution, you are going to have that thing in mind when you are mentoring your students. While when you are working in private practice, you will have that practice in your mind when you are mentoring your patients, students. So the important thing to ponder about is there are a lot of private practitioners who would like to come and experience, give their inputs or teaching or whichever way they want to institutional practice, so that the students also will have two different aspects of the practices. They will know about it, they will know what they are doing, people are doing outside. How we are going to make it easier for these people who are working in private practice to come to the institution and do this and help out?
For that, we are in the periphery, we are appointed the consultant, and it has been started, our directors, madam and the dean madam, they are all started the consultant in the private. So it is not in our institute for medical college, but it is there in the other hospital, peripheral hospital.
So I'll make, with the permission, one quick comment as a summary of whatever I have experienced in last 20 years. So when you start your career, for the first 15 years to 20 years of your career, you have to choose 2 things out of 3. The 3 things are money, fame, and quality of life. You have to choose 2 out of these 3, and depending on what 2 you choose, you decide whether you will be in private practice, teaching institute, or both. So if you want quality of life and fame, you take a teaching institute. If you want quality of life and money, you go into a private practice. But if you choose the difficult 2, that is money and fame, and you are willing to leave aside the quality of life, then you choose a combination of the 2, which many of us are doing.
My question is to Dr. Nitin Dange. Dr. Nitin, you must be having, you had students in KM Hospital, you must be training them, and now you have students as a DNB students in private also. So what are the challenges like in private and in institution, how you handle them?
Very important question, especially to a surgeon. Basically it is, I can say, I value the volume of patients what we have in the institute like KM or SIAM, and the game changer for us, these students who are trained by me at KM or SIAM, they are much confident and they are much skilled because they get hands-on, which is a obvious difference which I cannot give in or train them so freehand in the private setup. So that's volume-based services. It's not that because patients are poor, I'm training them that way. It's the expectation of the patients. It's the expectation of the institute. It's the expectation of your branding, which is very, very difficult. But if you go behind the scene and ask about me, I give the same amount of work in the private as well as the KM, and I'm watching, I'm taking the responsibility, and that's why maybe I'm popular amongst the students, that I give lots of hands work.
Thank you very much.
Okay. To summarize from this side.
Hello. Just one comment.
Sure.
I would it would be nice for me to say, I remember Dr. Deval, sir, my ex-HOD anesthesia. He, once upon a time, while leaving for home at gate number 3, he just asked me, Shashikant, when are we going to stop this 10 rupees at the admission counter that we are charging for, and what are we charging for? That he asked me that question. Do we have that answer today that we have to look upon? That is why we should research and research and research for that quality of life for us as well as for the people of India. Thank you.
Okay.
वो सुबह कभी तो आएगी, ऐसा मैं सोच के ये बता रहा हूँ कि आप एक as a good citizen of India and a good doctor, you should vouch for that, and that's why you should be here. Thank you.
Thank you, sir. That was the
Dr.
last
Shinde,
audience question.
Dr. Shinde, your point is well taken. And just to summarize my thoughts on this process, I think a combination of private and academic practice is essential even from the practical point of view. People have this status about doctors, their spending abilities, the way they look, the car they drive, things. And it is difficult for us, as it is for every other middle class income taxpayer. I remained in academic practice because I loved my academic practice, and my husband was funding with his credit cards. But that's not, I'm very grateful, but it is difficult to strike that balance. But eventually, and in the end, I think it is each individual's personal commitment, patient-centric care, to student-centric care. And I think once we have that in our head, no matter whether we are in private or otherwise, I think we've already won the game.
Thank you, panelists. I'm sure we had very good take-home messages from both sides of the panel. I would like to thank panelists for the insightful discussions and their final thoughts. As we conclude this panel discussion, we hope that our audience has got a deeper understanding of the opportunities and challenges, both in institutional as well as private practice setting. We encourage the audience to continue this conversation, share their thoughts and explore the ways to collaborate and improve healthcare outcomes as they discuss this further amongst themselves. On behalf of the organizers, I would like to thank our panelists, my fellow moderator, the audience, and for participating in this enriching discussion. Let's continue to work together to shape the future of healthcare. Many a times we say that we are in a cage, but that cage is made of thoughts, and those thoughts belongs to us. So if we decide to move out of that stage, there is not many people to stop you from moving out of your comfort zone, out of the stage, and actually do what you think is the right thing to do. So thank you all for your participation, and thank you, audience.
Thank you, Dr. Aditi and Dr. Alok. Now I request Dr. Aditi ma'am to felicitate our first moderator, Dr. Sandesh Parilkar. I request all the panelists to exit from the right side.
Who's right? Your right or my right? That's the question.
My right. I request Aditi ma'am again to felicitate Dr. Shilpa Rao. I request Aditi ma'am to felicitate Dr. Smati Tiwari. I request Dr. Alok to felicitate Dr. Akash Shukla. I request Dr. Alok Patil to felicitate Dr. Nitin Dange. I request Dr. Alok again to felicitate Dr. Ujjwal Rathod. I would like to invite Dr. Charan Lanjewar to felicitate our moderator, Dr. Aditi Fulpagar. I request Dr. Mohan Desai sir to felicitate our next moderator, Dr. Alok Patil. After the group photo, we will be moving on to the next session. Throughout history, highly successful physicians have always been defined by their medical knowledge, reasoning skills, and ability to communicate properly with their patients. A new factor has recently been added to the list of physicians' publication record. A rapidly growing numbers of indexed new articles every year demonstrate the growing attention physicians have to pay for their academic publications. The current panel discussion, Publish or Perish, focuses on the same. Our first moderator for this panel discussion is Dr. Anamika Agarwal, Professor and Unit Head in the Department of Ophthalmology. She is an avid researcher having numerous publications to her credit. Her areas of interest are pediatric ophthalmology, medical retina, and diabetic retinopathy. Our second moderator for this panel discussion is Dr. Shrikanta Oak, Professor Additional and in the Department of Anesthesiology. She is a mentor for Neuroanesthesia MUHS Fellowship. She is a teaching faculty for various CPCR workshops. She has many publications to her credit. Her areas of interest are neuroanesthesia and difficult airway. Please welcome Dr. Anamika Agarwal and Dr. Shrikanta Oak on stage.
Thanks a lot. Very good afternoon, respected Dean Madam, invited dignitaries, my dear friends, and respected teachers. Research is essential to carry science forward, and it is done to benefit patient, physician, and community at large. Publishing is now becoming the way of life, with its positive and negative effects on researcher. It signified the rising importance because of two factors. One is to obtain the research funds, and to establish a secure academic career. Like for promotion, 2 to 4 publications of original articles in an index-specified journal is must. Every day, 5 to 6,000 papers, and every new journal is coming up globally. And teaching hospitals play a major role in this. To discuss this all aspects of publication culture, here we are with panel discussion on publish or perish.
Good afternoon, everyone. At the outset, I would like to thank respected Dean Madam and Research Staff Society for giving us the opportunity to conduct a session post-lunch session. Okay, after that relishing food and hot and spicy topic of institutional versus private practice, let's take the journey of publish or perish. Karo ya moro. Okay, so to take this journey, our first panelist is none other than dashing leader, Dr. Harish Pathak sir, our academic dean. None of our panelists require any introduction. They are stalwarts in their field. Sir is academic dean, and sir's interest is criminology and investigation, advances in forensics and administration. Let me tell you, he is a leader of the forensic. Let me tell you, sir is a leader of the medical legal department, which is Taran Har department in real sense. They are, whenever we go to them, 24/7 they are available, and they are like, "Main hu na," like that. The next panelist is?
Next panelist is Tushar Badga sir. He is the professor and head Department of Endocrinology, which is one of the best in India. And he is always mentoring his whole department into research and publication, and I could see it whenever I visit him. Our next panelist is Nitya Gopte madam. She is the professor and head Department of Clinical Pharmacology. She is a great academician who is into research, writing, publication, and she is on editorial board, and she is an excellent teacher. Our next panelist is Mohan Desai sir, who is the head of the department of very famous department, orthopedic. And he is balancing his clinical activities and administration very well. Our next panelist.
To take this journey further, I invite my big B, Dr. Avinash Ingole, who is the head of the Opthal Shining Department of KM Hospital, who is also a fitness freak. His areas of interest is cataract, anterior segment, oculoplasty, and pediatric ophthalmology.
And I could see the full session who is waiting for Big B.
Yes, that is another Big B. He's my Big B, Opthal. Okay. The next panelist is Devo ke Dev Mahadev we have seen, we have heard. Here we have Guruon ke Guru, Iyer sir. Iyer sir doesn't require any introduction. The way he conducts MEU is just phenomenal. Sir has trained me in this MEU very well. Sir has interest in student assessment, program evaluation, neuroanatomy, clinical anatomy. I take this opportunity to pay respect to my teachers, Urmila Thatte madam, Shir Sagar madam, Rege madam, Geeta madam, Natarajan sir. I respect you and I salute you, and I bow down before I start my session. We'll start the question.
Good. Hello.
My first question is to Harish Pathak, sir. Sir, considering the National Medical Commission NMC mandate requiring faculty to have publications in accredited journals as a criteria for promotion at every stage, what could be the rationale behind this, sir?
Thank you. See, a lot of thought process has gone at National Medical Commission before they made it mandatory to have research publication, original articles, original research articles. Some of them is like, number one, promote evidence-based medicine. As many of you must be knowing that once upon a time, they said, if you purchase a Mercedes, you should keep on driving till you can drive the same car. But now every year there is new addition. Similarly, even medicine is advancing very fast. Unless you have kept yourself up to date, you will be lagging behind. Then in an era of so many medico-legal cases of negligence against doctors, it's necessary that we should remain updated. Third thing, gone are the days when we could stand in the witness box and say that in my 30 years of experience, what I have learned based about that, this is my opinion. Very next question is, have you published those observations? Have they been peer reviewed? Only then it is an evidence, otherwise it is not. So there has to be a culture of research among the medical teachers. So foster a culture of lifelong learning. There are two professions where we only practice lifelong. One is medicine, second is law. And it's lifelong, you have to keep on learning. And that process has to continue. Third, enhances quality of medical education. Needless to say that when you are into research, you have to keep yourself updated with the latest, research in your faculty, so it will naturally enhance the medical education. Develops critical thinking and analytical skills. I remember when we started MD Forensic and I tried to give a good thesis to one of the students. Two faculty members told me, sir, it's not like this. This thesis is for the namesake. It has to be review of literature or whatever is in existence in the papers in MRD department. You have to go through that, like incidents of head injury in and around the city of Mumbai. Hardcore research is not required. This culture has to change. Therefore, original research articles are required. It advances medical science, encourages collaborations. Now, when it is mandatory that you are into research, you have to publish research articles. Today, we are in the process of having collaborative research MOUs with IITs, because you have to collaborate with other departments, other institutions to have a quality research. And last, it improves patient care and aligns with global standards. This problem in medical research and people having issues why you have to publish so many articles has started coming up after as newer and newer private medical colleges coming up, and there are more objections from them why you are making it mandatory for our teachers to have research papers. And now this is forcing them to have research infrastructure, because unless their teachers will do research, they will not have publications, and if there are no publications, they will not get promotion. Even if they are promoted, that will not be recognized by NMC. So there is a lot of thought process, and I believe was a very wise decision to have such criteria for promotion among medical teachers.
Very well said, sir. lot has been discussed between private and public practice. How does emphasis on publishing research impact the corporate setup where there are many DNB seats and everything? These NMC rules apply to them? Mohan Desai, sir.
Yeah. Thanks for getting this important topic on a debate mode. They have put both the groups on the same way, that is for. So it suggests that we are not totally against, but I am against the term perish. Why should we perish? It's okay that we publish, but if we don't, then so let's understand why and how this term started or existed. You know, it was for getting the funds for the research. The basic purpose of publishing is to disseminate knowledge, science, okay, but there are not so altruistic or noble reasons for publishing. One is to get academic promotions or higher position, to get a fame or reputation, establish yourself in the cutting edge or competitive market, and to market. So you can understand,
true,
in the corporate world, these compulsions are not there to get academic promotions. The funds, marketing, to get reputation may be the causes.
True, sir. Very well said. My next question is to Dr. Tushar, sir. Sir, we have so much of pressure, publish or no promotions. What do you think, sir? What is your take? Does this really compromise our routine clinical work or patient care? What do you think, sir?
So I think it's a misconception to start with, to say that if you go into research or if you try to publish the data which you are trying to get out of patient care, it is going to reduce the outcome, or it is going to have a negative effect on patient care as well as management. So I would like to give an example of simple data collection which we do. So what we do is, even if you look at retrospective case series, so we have so much patient workload, and if we devote 80% of our clinical time in managing patients, and even 20% of the time if you are able to just collect the data, analyze it, so it comes in a simple pro forma based evaluation. So what we do is, we take the Xerox of case sheets which we see in the OPD and put it up as a part of follow-up. So every follow-up the patient comes, then this data has been kept there. And at the end, we have huge amount of patient workload which has been collected at one place. So to give an example, when I was a student in 2002, that time I was told to give a talk or a presentation on hyperthyroidism. And so what we did was, we took out those proformas of 500 patients where the follow-up was there for 4 to 5 years, and where so many earlier endocrinologists had looked at, managed, and just analyzed the data, where you looked at clinical features, biochemistry, investigations, the treatment and the outcome. And at the end of the day, maybe in 1.5 months, my knowledge as well as understanding of that disorder was far better than my colleagues. So it is just by looking at the data, I did not waste my time, I was still doing my clinical work, and at the end of the day, so my better understanding of that topic improved patient management also. And we could publish a part of it in the journals, we could present it also. So the idea is that it cannot be impacting your patient outcome, it's going to be positively affecting the patient outcome only. That is the basic message. It not only involves and improves the personal skills, professional skills of the individual, but also gives a name to the department as well as to the institution if you are able to publish what you practice. So that's the way I look at it.
Very good suggestion, and now we are getting computer also. So we can have a good collection of data.
And also the internet facility which is available, I would say that's really great.
Nitya madam, what are the challenges of translating the public research into patient care centric research? Like, what efforts can be taken for converting them into making protocols and guidelines?
Thank you so much for having me on the panel. I'll just give you 2 examples about translation into patient care. So 20th of May is celebrated as Clinical Trials Day, and the reason is that James Lind went on this HMS Salisbury and randomized patients to either receive, the sailors to receive either apples and oranges or not receive apples and oranges. This was because all the sailors developed scurvy because of the long voyages. However, vitamin C took 40 years to actually reach the market as treatment for scurvy. So the NIH has actually done a lot of studies looking at how long does it take for evidence. If you have evidence today, how long does it take for it to reach actual practice? And the answer is 17 years. 7 years for you to be actually able to change practice. And I think what's important here is to understand the determinants of why this is so. And I think there are a lot of determinants. Everybody sitting in the audience must have taken the COVID vaccine. So what did we do for the COVID vaccine? We just put our hand out and said, give it to me. But it doesn't happen like that today. So it's risk benefit, it is community engagement, stakeholder engagement. If you look at certain neighboring countries today, they have a lot of polio. We don't have. So political instability, political will, the ability to change guidelines rapidly. And we must also not forget that we have a large rural population. So access to medication, and I think involvement of stakeholders, all of this will go a long way into translating public research or research into evidence and policy. So I don't think there is an easy answer to this question, but it's important that we try our best.
Yes, so lots of determination, patience is required.
Very well said, madam. Very truly pointed out. In a municipal setup with so many challenges around us, my next question is to Iyer sir. So what do you think? There is a lot of inertia in teaching faculty to publish due to so many challenges that are encountered. What do you think can be a solution for this?
Okay. So when we look at the term inertia amongst the faculty, what we are looking at, I think what inertia means is maybe the level of motivation that exists amongst the faculty members, or simply the amount of time that is spent in all other responsibilities that is allocated to faculty members. So let us look at three things. One is, if you look at role of medical teachers, there's a paper nicely written by Ronald Harden, one of the doyens of medical education from Dundee, Scotland. He talks about the 12 roles of teacher played by a medical teacher. And he has broadly classified those 12 roles under 4 headings. Those 4 headings are: a medical teacher is an information provider. At the same time, a medical teacher is a source of information and facilitator of learning. He is also an assessor and mentor. And of course, when I say he, it also means she. And at the same time, the medical teacher also plays a role as a role model and also a scholar. Now, when we say scholar, one of the things that he does as a scholar is research. But whether there is enough level of motivation to do that research work, because of probably time getting spent in other responsibilities as medical teachers amongst those roles that I just specified. So there is a feeling amongst the faculty members, as far as challenges are concerned, is that research and publication is a special task. And as Dr. Tushar rightly said, I want to reinforce this point, that this is probably incorrect, and all one needs to do is find research in day-to-day activities that we are conducting. And another feeling also among the faculty members is that all the remaining roles that medical teachers play is undervalued and rather given very, very little value by the regulatory authorities. So that's another challenge. Maybe there may be inadequate skills and capacity among the faculty members that also probably demotivates people to conduct research and publish further. So what can be done regarding this? Maybe conduct workshops, participate in workshops, getting that capacity built among the faculty members. And of course, the current era is digital. So take that digital leverage, use digital platforms to learn about them. And there is an era of massive open online courses that got a boom, especially with the COVID-19 pandemic. So enough opportunities available. Collaborative learning platforms are available, so that can be used to enhance capacity amongst the faculty members. And thirdly, as this discussion began with the NMC guidelines and the rationale behind the NMC guidelines, to promote evidence-based practice, we all will agree that original research papers, systematic reviews, meta-analysis have their own places in research. But unfortunately, if we look at every case that is managed by a clinician, I believe that every case managed by a clinician is quite unique. So therefore, the uniqueness itself has to be reported as a narrative, and we all know that that gets reported as a case report. However, in the guidelines, case reports do not find value, even though case reports may have the maximum number of citations in other original research papers. So probably this is a way that people need to look at and change, and that will probably motivate further the faculty members to do research and publish.
Very well said here, sir. I request Pathak sir, please take this point somewhere. Ki case report really have practical implications, but they are not credited. So that is the reason why these case reports are, we are not encouraged to write the case report. So something should be done about it.
I want to add few more things. One thing, there are many more. For example, book chapters. Now, dissertation itself, we have put 3 years, and that is not given weightage. That is accepted by the university, done, there is a review board here, but that is not considered as any publication, and we give weightage to something which we are publishing in a journal which is not affiliated to the university. So monographs, book chapters are not given any weightage. So I think these should be considered. In the UGC there is a score, I think it is API score or something, that takes hours of teaching classes that you have taken, all this presentation on the podium, that is not given. So when will people present on the podium? If you are giving this, we have lost focus. We focus only on publication, and we lose the focus on other aspects, teaching, clinical aspects, so on and so.
I hope
someone... I want to say one thing. See, it has become like this, like people hate fastening seat belt, and because आगे पुलिस वाला खड़ा है इसलिए I want to fasten the seat belt, forgetting that you should fasten seat belt because it will protect you. When Volvo invented this technology, within first year 70% of the fatalities, road accidents were reduced. Police has made it mandatory for your safety, not because they want to charge 100 rupees fine. Similarly, you publish, you do research, not because NMC says that. They say minimum 4, 5, 6, 2. Do it because it will make you a better medical teacher, better medical practitioner, and better mentor for your students, and not because NMC says that you should do it. Only then you will do a quality research and you will be motivated. Thinking that because NMC says, therefore I had to do it, that approach itself is wrong. Nobody discourages you. When we take interview, if you have written a chapter, we take it into consideration. If you have been invited for a talk, we take it into consideration, but it's nothing, everything need not be written. But there is something mandatory because they thought people are not doing it. But that doesn't mean that you should start hating something which has been made mandatory. It has been made mandatory to make you a better teacher, better physician. And you said, why perish? I'll tell you why perish. You have done fantastic surgery. You have done 100 surgeries. You learn some technique and you publish and you say this is Desai's technique. Right? You do it, and if your patient sues you that you have done something which is not accepted and it is not accredited, you can be punished. Unless you have published it, it has been peer reviewed and accepted by a journal and your peers, only then you can practice and you can propagate that technique.
Sir,
so it is legally also good that you should. And last, whatever wisdom you have collected during your years of practice, you discovered a few things, maybe you invented few things. It shouldn't go with you in your coffin. Let the coming generations get benefited with that. Therefore also publication is important. So have a holistic view rather than only NMC क्यों बोलता है और इसलिए बोलता है इसलिए मैं करता हूँ. That attitude is, I think, incorrect.
Sir, it is well said, sir. The creativity has to be from the internal motivation. It cannot be from external motivation. Under the pressure, the artist cannot perform.
I hope someone from here will be in NMC guidelines, who will formulate the NMC guidelines. Case reports and thesis get some weightage. Sir, Avinash Ingole sir, are we sacrificing the quality and applicability of research in medicine due to the focus on the quantity of publication? As we can see, everyone CV mention how many publications, how many presentations. So are we sacrificing?
Thank you so much. Yes, the emphasis on more publications. You always judge people, oh, how he's got 200 publications, he must be great. But what kind of publications, quality of publications, that really matter. Basically, why the number of publications are taking place, there are a few reasons behind it. One is increased visibility in the academic fraternity, or certain institutions like Dr. Pathak said, certain institutions, they hire you for more number of publications. He has more number of publications, obviously he should be selected. Or career opportunities, also networking opportunities. These are few reasons why the number of publications have been made. Another thing, sometimes some people just want to try different journals just to send articles and get the hang of it, how the articles are published. But the quantity publications definitely have got certain disadvantages. One is reproducibility issues. Many times certain things which have been published, which are almost impossible to reproduce, or then certain things like a single article which has been made, but which is again divided into something known as salami slicing. It is made and it is been published in various different journals, fragmenting the whole purpose of the basic question as such. Multiple studies may address the same question. Many times you see on the same topics, different journals, different publications. So that is also bad. As you know, many journals, they do take money to publish their articles. And in that case, the question of authenticity always comes in. As you know, during COVID era, we have seen the number of publications being quite high. And that again raises the authenticity, whether this article is really worth reading and whether it is true or it is been published during that era. That was also a question. So the quality publication should be more impactful, and the basic purpose of quality publications is it causes advancement of the knowledge and the technology. You try to learn something and implement it to the patient care. So in the end, I would like to say there has to be a balance between quantity and quality. Second thing is the pre-registration studies. Certain articles are published only when the findings are clinically significant, which may not be true because sometimes, statistically significant. But clinically significant findings also can be worth, or findings in which it's negative or inconclusive, also effective in learning something. Peer review analysis, collaborative studies are also few things which should be considered when publishing the article. So whenever you look at an article, it should be impactful, it should be properly studied as a whole rather than, and reproducibility, that is the most important thing that should be considered when you see an article. Thank you.
So nicely said, sir. But क्या करें? Promotion का सवाल है.
We are thinking in terms of author's point of view.
Yeah.
But let's think from the reader's point of view. Now, if I had to keep updated, yes, Dr. Pathak sir made a valid point that you had to update yourself, upgrade yourself. But if in my subject or in say joint replacement, I read 3 articles a day, even then it would take me almost 1 year to finish reading all the articles from all the journals published in that month. So look at the plight of the readers, that the culture we have created, it is creating not the true research papers, but perhaps I won't say the analogy. You get the analogy. You see, Archimedes, Newtons, and Einsteins are once in a lifetime. They make path-breaking discoveries or research. You have to be as crazy as Archimedes to run naked in the crowd and shout "Eureka" to have that clinical impact. You have to have publication should have clinical impact. Otherwise, it would be other paper.
So then what do you think? So who will get benefited? Researchers?
There should, publishing is okay, but there should not be any compulsion.
Harish sir, how can institution deal with unethical practices? As sir mentioned, there is a salami slicing, duplicate data, duplicate publication, fraudulent data, plagiarism, manipulated results. What is your take? How we can avoid this?
Number one, don't remain silent witness to such fraudulent practices. You only discuss in Gurukul, only you discuss in canteen, but you do not complain. You say my colleague, my boss, my subordinate has published this bogus paper or fraudulent data, but you don't have guts to write a letter to the editor or to the dean or dean academics that such and such malpractice has happened, sir, please take action. Till such time you remain silent witness, things will go on. Even forget your institution, in other institutions it is happening, but you don't take the courage to write a simple letter that this has happened. Not only that, I know very good scholars, good researchers, they say my data has been stolen and published by such and such person. When I say write a letter, they don't. Till such time you remain a silent witness, it will go on happening. That is one thing. Second thing, don't subscribe to low class journals. Don't publish articles in, therefore when we nowadays take interviews, we say how many articles, how many case reports, how many original research, and last but not the least, out of that, how many are PubMed. There was a lot of pressure from especially private medical colleges. Please don't make it PubMed, then Scopus, then Aate, I don't know how many types of journals are now accepted for publication for the purpose of promotion. We are ourselves want to increase the scope of not good research but scope of ease of publication so that we can get promotion. So if we collectively work so that fraudulent or low quality data or fraudulent data is not published, we can avoid this. And it's an old saying that बहुत ज़्यादा चूहे तकलीफ दे रहे हैं तो एक चूहे को मार के लटका दो, बाकी चूहे भाग जाते हैं. वो एक को मारने के लिए भी कोई लेटर तो लिखो. Nobody is willing. सर बड़ा वो उसके 200 पेपर हैं, उसमें से 100 मेरे आँख के सामने बैठ के उसने लाइब्रेरी में लिखे हुए हैं. ठीक है, उसका नाम भेजो तो, किसी को बोलो तो, नो, वो मैं क्यों बोलूँ? So it's like as simple as PCPNDT एक्ट पे एक डिबेट हो रही थी. सर so many people do it, right? Complaint, sir that is not my job, why I should write against my own colleague? Government cannot remain silent. So they have such a policy wherein there is collateral damage. But government has to come out when the sex ratio has gone so down. Similarly, are there fraudulent publication? Yes, we all agree. Bogus data hota hai, we all agree. But nobody wants to take a pen and write a complaint. So don't remain a silent witness. Slowly and steadily it will come down.
एक चूहे को पकड़ो.
एक चूहे को पकड़ के मार के लटका दो.
In continuation to this, my next question is to Nitya madam. Madam, what do you have to say about this gifted and ghost authorship? What is your take on that?
Yeah, so before we go on to gift and ghost authorship, I thought I'll just read out who is an author. So once we know who is an author, then we'll know who is not an author. So these guidelines are from the ICMJE, International Committee for Medical Journal Editors. So it's and, it's not or. It's important to remember it's and. So you have to have substantial contribution to conceptualizing the study or designing it or analyzing it critically. And you have to have a first draft of the manuscript that you've written and approve the final version. But I think the most important and is accountability. You are accountable when your name is on the paper. So once all these ands are satisfied, then you truly qualify to be an author. As regards ghost authorship and gift authorship is also called as honorary authorship. It happens a lot. I'm not sure what can be. These are very difficult questions to answer, but the one message that I would like to give, and this is in continuation with what Dr. Pathak has said earlier, is that please look at this website called COPE, C-O-P-E, Committee on Publication Ethics. There are very nice standardized charts, flow charts, which tell you what to do. And I think Dr. Pathak and Dr. Desai, we should have these mechanisms and systems in place in our institution. So should there be a complaint or something in future, we have our plan of action ready. And the last thing is something called as credit. Today, journals don't ask you about first authorship. They ask you, what did you contribute? Did you contribute to the statistical analysis or did you contribute to data acquisition? So there is contributor role taxonomy, which has about 13 or 14 items. So it's important to understand that contribution is more important than, and I think at the end of it all, we have 2.5 minutes. I think it's your, it's all within the voice within, so your personal integrity, that I think is really, really crucial in all of this. Having said that, these things are going to happen. Mechanisms in place, SOPs are very important.
That's why ethics play a role. Ethics committee approval plays a role.
It's beyond ethics committee approval actually.
Because many of the spouses only they put their name and they means they have help in writing.
Yeah.
They say the contribution like this.
You said many of the spouses.
Many of the resident they
Achha,
write
okay,
their
okay.
spouse's name.
Achha, okay.
If they are from the same department. Yeah, sir. We have seen this.
I know few examples in which whenever the resident wants to publish any paper, the HOD or the teachers used to say, put my name first. Means I don't know what is the funda behind it and what about the person who has worked for the article. But unfortunately this is true.
I know one institution not very far from here, when in this CEO has published 250 papers, being a dentist, and her name is there in the medical genetics also, all. So the CEO says my name should be there everywhere. But nobody has guts to write us one letter against her. Nobody. So it happens, it shouldn't happen. And if one action is taken, all the papers will be scrutinized. But that doesn't happen. And yes, if you are a guide, as per the MUHS guideline, you are the chief investigator, your name should be first. But for any other article, unless you are the lead researcher, insisting that my name should be first, not only put my name should be first, that is unethical. But I have not received a single complaint of that time. And I am waiting for that.
So this is the final question. For balanced approach and practice and publication, do you think regular CME, fixed allocation of time during duty hours for research will help, and how institute can help facilitate this? And you can conclude, sir. Praveen, sir.
So taking a point ahead from my previous question's answer that I gave, and reiterating what Dr. Tushar said, in daily practice, we find observations and then take it ahead as data and then conduct research, and that leads to publication. So how do we do it in our own setup? Right now, it is initiated by the researcher. That is where it is. So can institutions make policies regarding this? So support, how can institutions support the faculty members to conduct research and take it ahead till the state of publication. So maybe infrastructure and administrative support is one heading that we can look at. There may be dedicated research units. There are in our institutions, but maybe their role may be a little enhanced to assist and facilitate the faculty members to take it right from beginning of research till the end and culmination into publication. So we may try to look into that aspect. Then of course, in our routine duties that we perform various roles, we can think of flexible scheduling and allocating dedicated time during the course of the week, the month or the year for research purpose and writing publications. And at the same time, incentives can be thought of for faculty members in the form of sponsorships for training programs and capacity building. At the same time, maybe supporting them with seed grants, intramural grants, and also rewarding them for publication in high impact journals. So these are the things that I consider that may be the things that can be done by institution for supporting.
Thank you, sir. I take this opportunity to thank all the panelists for the wonderful discussion. From publish or perish, Geo ya Maro, from this concept, we go towards prosper and patent. All is well. Thank you.
I request all of you to be here for felicitation, quick felicitation.
Thank you, Dr. Anamika and Dr. Shrikanta. I would request Dr. Anamika Agarwal to felicitate Dr. Harish Pathak. I request Dr. Anamika ma'am again to felicitate Dr. Tushar Bangal. I request Dr. Anamika ma'am to felicitate Dr. Nitya Gupte. I request Dr. Shrikanta ma'am to felicitate Dr. Mohan Desai. I request Shrikanta ma'am to felicitate Dr. Avinash Ingole. Lastly, I request Dr. Shrikanta ma'am again to felicitate Dr. Praveen Iyer. I request Dr. Roshan sir to felicitate our moderator Dr. Anamika Agarwal. Roshan sir, please felicitate Dr. Shrikanta Oak ma'am. Now we reach the end of the session.
Thank you everyone. That was a wonderful time, scientific agenda conducted by Staff Society. Now I request all the delegates to leave the hall because we need to sanitize this for Z plus security of Mr. Bachchan. We'll start the entry into the hall after 1 hour, exact time 1 hour. So you can have a tea coffee in our Dean lawn, but this whole area will be sanitized. So please take away all of your baggages because if unknown baggages, we have to take it out. So don't leave any bags, anything which can be thrown out. So sincere request, please vacate the hall. I'll request even the audiovisual team to vacate the hall. I will request even the housekeeping agencies to leave the hall. I will request the media persons, photographer, things to leave the hall. Thank you everyone. Please understand that this is a historic moment. We don't want to create any issues. And please be abide to the rules and regulations. We have volunteers and bouncers. If you have any issues, you can talk to any of the organizing team member about the facilities and things which are arranged here. Thank you.